Good morning, everybody. Happy Saturday. Welcome to the MGFA Southeast Regional Conference. We have a very exciting program today. We actually have 3 volunteer organizers. We have Kathy Timothy, who will be moderating today, and Pam Alec. They are the support group leaders in St. Petersburg. And we also have another volunteer, Jenny Clark. We definitely want to first start off by thanking our sponsors who make this possible: Alexion, Argenx, Janssen, UCB, Immunovant, Horizon, Accredo, and Sanofi. We have a really exciting program today. This is our agenda. And what we like to ask, because I think everyone's pretty good at after all these months and months of doing Zoom calls, please stay on mute. When we have our Q&As, we will ask you to put your questions. At any time you have questions, put it in the chat, and we will be watching the chat, and we'll be moderating the questions. So as that, I am going to stop sharing, and I am going to allow Dr. Rosario to pull up his slides. And Kathy, it is all yours.
Thank you. Good morning, everyone. We're so lucky to have Dr. Rosario with us today. Dr. Rosario was born in Puerto Rico. He initiated medical school in Guadalajara, Mexico, before transferring to New York Medical College, where he successfully completed medical training. He then completed a neurology residency at University of Connecticut in 2012, where the interest in neuromuscular disease was started. He then transitioned to Duke University in North Carolina, where he completed a neuromuscular disease fellowship in 2013, followed by an advanced neuromuscular disease fellowship in 2014. He then moved to St. Petersburg, Florida, where he has been faculty with Bay Care Neurology Group and the Tampa Bay Muscular Dystrophy Care Center. Dr. Rosario, and by the way, Dr. Rosario, go Huskies.
That's right. All right. Good morning, everyone. This is a lengthy topic, and we only have 45 minutes, so I'm just gonna go ahead and get into it. Can everybody hear me well?
Yes, we can.
Okay. And can everybody see the slides well?
Yes.
Okay, goals for today. We're going to learn what are the treatment options in myasthenia gravis. Above all, I really would like to show how do they work in the mechanism and why do they work? Why do we choose these medicines for myasthenia? How do they work in the pathophysiology of this disease? There are different treatments in myasthenia gravis. Things like lifestyle modifications, some exercise. I believe this is going to be touched more later today. Part of treatment is understanding your body and understanding what things to avoid, what things to do, what things not to do, recognizing some of the early symptoms to avoid worsening. There's also pharmacological treatments. There's symptomatic management with medication like Mestinon, for example. There's also immunomodulatory medications like Prednisone, and there's some other oral ones like Celsep, Immunosuppressant. We're going to be touching on these later today. There's also some IV immunomodulatory medications like Solaris, Ultomiris, or Vyvgart. In addition to the pharmacological treatment, there is also interventional procedures typically done in emergency settings, and that will be plasmapheresis or IVIG. Finally, there's surgical management of myasthenia with thymectomy. But from all these treatments on today's chat, we're going to be focusing on pharmacological treatment and the emergent management in myasthenia. Let's start with Mestinon. But to understand how Mestinon works, we really need to know about the neuromuscular junction physiology. And these are very complex topics. And I'm gonna use language, and I'm gonna use pictures that hopefully will be easy to understand. Hopefully, I can transmit a complicated topic into something easily understandable. But to your left, you see here, this is the neuromuscular junction. Down here, can everybody see my pointer? As it move, anybody can see my mouse?
Yes,
we
Dr.
can
Weiss.
see you.
I mean, Dr. Rosario.
So this is your nerve, okay? And this down here is the muscle. And between the nerve and the muscle, we have the neuromuscular junction. When we decide when we decide to contract a muscle, either voluntarily or involuntarily, when we do this, our brain sends down signals through the brainstem into the spinal cord, from the spinal cord into the nerve, and travel down here. Once it gets here, the nerve releases these vesicles. These are acetylcholine vesicles. And these vesicles now are going to flood that junction, the neuromuscular junction. And these are all these red dots. And hopefully they're going to find an available acetylcholine receptor. These receptors are in the muscle membrane. So like this one, for example, okay, this one, red one here, finds this closed receptor. And once it binds it, it opens it up. And then there's some chemical reactions that occurs. Eventually that will lead to muscle contraction. Okay? And that's the normal physiology of the neuromuscular junction. What happens inside, within this junction right here, within this space, we have this enzyme here in the corner. It's called the acetylcholine esterase. And this enzyme here that looks like a little Pac-Man, the job of that enzyme is to eat away all of these pebbles, all of the acetylcholine vesicles right here. Okay. Here in this other picture, we have the receptor, and this is the myasthenia antibody in green. Basically, it is covering the spot where the acetylcholine should bind so that it opens it. So when we have the receptor right in the middle covering the site, then the acetylcholine will not activate that receptor to open up and follow the chemical reactions that leads to contraction, that leads to weakness. So how Mestinon works is the following. You remember this enzyme we just talked about, the acetylcholine esterase, and the job of this enzyme is to eat all of these vesicles of acetylcholine right here. So what Mestinon or pyridostigmine, what it does is it pretty much blocks it. It shoves it in the mouth. It blocks it. And when this enzyme is blocked, when this acetylcholine esterase is blocked, it can no longer eat all of the little pebbles, all of the acetylcholine. And that creates more acetylcholine available in the cleft, in that space. I'm sorry. It will leave more of those. Now our junction is going to be full of acetylcholine because the Pac-Mans that eats them, it's blocked by the Mestinon. When we have a lot of them, let's say now we have a lot because all the Pac-Mans have been blocked and they're not eating them, they accumulate, they aggregate. And then eventually they will gang up and they will take the receptor and they will push it away. And that leaves the open site so that the vesicle or the acetylcholine reach it and eventually leads to contraction. And that's how and why Mestinon works. It blocks the acetylcholine esterase. When it blocks it, Now it leaves a lot of acetylcholine in the junction, and all that acetylcholine will gang up and will scare away and push away the bad antibody from the receptor, leading to improvement in strength. Mestinon comes in 60 milligram tablets. They're often scored. There's a time span option, which is like a extended release option. There's also a syrup option, liquid. And there it also is a IV or intramuscular option. Okay? That one's left pretty much if you're unable to take any oral medications. Don't let anyone give you IV Mestinon, please. If you cannot take any oral Mestinon, then you want to do intramuscular Mestinon. The reason is IV Mestinon can cause cardiovascular complications. Mestinon works at the neuromuscular junction. We just talked about that. And it provides temporary improvement in strength. Starts working in about 20 minutes or so, then peaks in about 45 to 60 minutes, and it lasts anywhere between 4 to 6 hours. So that predictability on how it works, when it peaks and how long it lasts, it helps us, the clinicians, to better, to guide your treatment. It helps us understand what kind of dosing, how often, how high of a dose, or how frequent of a dose the patient will need. It does not have long-term side effects. It does have short-term side effects while the medication is in you. And the most common are being gastro, things like diarrhea, abdominal discomfort. You can also have salivation, lacrimation, muscle twitches, etc. The dose is individualized, and standard dose varies between patients. Some docs start at 30 milligrams 3 times a day, but that might be too much, or that might not even touch you. Everybody is different. And it is advanced as tolerated. As discussed, some of the common side effects are nausea, vomiting, abdominal cramps, lacrimation, salivation, muscle twitches. Please be mindful, a lot of Mestinon is bad. Okay, about 45 minutes to an hour during the peak dose. If you take too much, it can worsen myasthenia, it can cause weakness. It can also slow down your heart rate, and it could be dangerous. So too much Mestinon can be very dangerous also. We're talking of Mestinon working at a neuromuscular junction level, meaning that really does not alter your immune system, being myasthenia and autoimmune disease. It does not affect, it doesn't stop your immune system from making the bad antibodies. You can take all the Mestinon in the world, your immune system is still producing those bad antibodies. To understand how immunosuppressants work, to understand how to reduce that antibody production, we need to have some knowledge of immunology, basic immunology, because it is very complex. But as you all know from when you get your CBCs in your blood work, you have different type of cell lines. You have the red blood cells. You also have the platelets. You also have the white blood cells, and within the white blood cells, there's other cell lines. The important ones here are the lymphocytes, and these are when we're talking about myasthenia, these are the important ones. And that B cell right here, this B cell lymphocyte, will transform into plasma cell, will change into a plasma cell. And the function of plasma cells is to produce immunoglobulins. Immunoglobulins can be used interchangeably with antibodies, but it produces immunoglobulins. And there's different types of immunoglobulin. There's IgG, there's IgE, IgM, IgA, etc. And all these IGs, or all these immunoglobulins, have different functions. For example, IgA has to do with the immune function of mucous membranes like your lungs or your gastro. IgE has to do with the parasites or asthma, pretty much parasites and that sort of stuff. But the important one here I want to bring to your attention is IgG. The myasthenia gravis antibody is an IgG. Our plasma cell produce IgGs, which protect us against bacteria, viruses, toxins, etc. So we have the plasma cell here, the B cell converts into plasma cell. Once we get a virus or a bacteria, this plasma cell produces IgGs. So this right here in green is our plasma cell that produces the IgG, which is a good antibody fighting against this guy. However, that same plasma cell can get confused and can form, and it will also be the one that forms the bad antibodies or reactive antibodies or autoantibodies. These are all synonyms. And these are the bad antibodies. And these are the antibodies that don't target the virus or bacteria. It's now targeting a part of your own body. In this case, the acetylcholine receptor. Now, the immunosuppressants, some of which are listed here, they work in different ways, right? They all have different mechanisms of action. We're not going to go through all of them, but the end result is that they kill that plasma cell, or they reduce the ability of that plasma cell or that B cell to produce. It reduces the levels of plasma cell. So in other words, all of these medications simplified will reduce or kill or eliminate, try to eliminate this guy so that it does not produce the bad antibodies. Unfortunately, remember that this guy also produces the good antibodies. That's why all of these medicines, they cause immunosuppression, meaning they lower your immune system. And that's how all those medications work. They reduce the B cell population or the plasma cell so that we get less of the bad antibodies. A little quickly on prednisone, it's oral. There is an IV alternative in case you can't swallow. It is relatively cheap, and it works. It's very effective in myasthenia. It does not work fast. It does take several weeks to start working, and the recommended dose is high dose. If you have generalized myasthenia gravis and you can't swallow, you're having problems eating, chewing, and you get started on prednisone 5 milligrams, that's not appropriate. Really, we should use high dose prednisone. And ocular myasthenia might be less than 60 milligrams, but it should be high dose prednisone. Okay, and then it gets reassessed over some time, and then eventually, once you're all better, we start a tapering process. And with prednisone, you need to expect side effects. And these are some of the side effects of Mestinon on your left. It's a whole list of their short-term side effects like insomnia, jitteriness, anxiety, reflux. And then there's some other longer term side effects like perhaps weight gain or osteoporosis, cataracts, etc. Here on your left side is a list of some of the most common immunosuppressants used. They're also coined as steroid tapering agents. You might hear that term also. Celsep, which is mycophenolate, Immuran, which is azathioprine, Rituxan, Solaris, Ultomiris, Vyvgart. And when do we use these? Well, we use those when we cannot taper down that prednisone. Right, so you start with the Mestinon, which does not have long-term side effect. If you still have symptoms, when we add prednisone, and then once you're better, we reduce prednisone. But if we are unable to taper off that prednisone, then we institute these medications. And which one to use, that's a shared consent, right? That's a shared decision with a clinician. The one we use depends on many things. It depends on the side effect profile of the medication. It depends on the frequency of administration. Let's say you're not used to taking a medicine twice a day like Celsep, but Immunosuppressant can be taken once a day, for example. Right? Also depends on your comorbidities. Let's say you have a history of meningitis, then I wouldn't use Solaris or Ultomaris. Or let's say you have a history of pancreatitis, then I wouldn't use Immunosuppressant. Right? So it depends on what kind of comorbidities you have, will help me choose an agent that's safer. Also, depends on how severe is your illness, because some of these, like mycophenolate and azathioprine, particularly azathioprine, they take many months to start working, and perhaps we need something of faster onset. Ultimately, the insurance has a lot to say, and I may want to start something, but your insurance might not approve it. I just want to spend this slide on Rituxan in case there's anyone with MuSK in the audience, or on Rituxan. I mean, it can be used also for refractory generalized myasthenia. And Rituxan is a monoclonal antibody against CD20. And I'm going to unpack what that means. Monoclonal antibody, many of these medicines are monoclonal antibodies, and you know what an antibody is. So a monoclonal antibody is an antibody that has been created, engineered in a lab by intelligent people that actually makes it. Okay, and this antibody, which is up here, and this antibody binds CD20, and CD20 is a protein that is in the surface of the B cells. All the B cells have in the surface this little yellow CD20s. And CD20 allows an optimal immune response. CD20 is the one that guides and moves around that B cell. Same way a jockey moves a horse in the direction where you want the horse to go. Well, that CD20 is kind of the jockey of the B cell. Without properly functioning CD20, the cell dies. Okay, and if the B cell dies, then the B cell does not convert into plasma cell. The plasma cell does not produce antibodies. And if it does not produce antibodies, then the myasthenia gravis antibodies are not produced. And that is how Rituxan works. It's an IV medication and is every 6 months. Works well in MuSK. Also used in refractory GMG. Ultomaris or Solaris. To understand these two medications, we need to know a little bit about the complement system. And our immune system not only has the IgGs and not only have the antibodies and different type of antibodies, but it also have this little circulating proteins around, and they're called complement. And they're called complement because they actually complement our immune system. They're not it, but they are part of it. Okay, so they improve the ability of the antibodies and those immune cells to get rid of pathogens. They improve the antibodies and immune cells to reach target organs. The same way a police officer directs the traffic and helps those vehicles come in and out and move safely around and help vehicles get to their destinations. In that same way, the complement system aids all of our immune cells and our antibodies to reach their target. And this picture here this red is our muscle, and our muscle have our folds here, and within this surface with the folds, we have the receptors. These are the acetylcholine receptors. Okay, and this in blue is a myasthenia antibody. In here, it is blocking one of the receptors. So acetylcholine cannot reach this receptor here. What happens? When the antibody reaches the receptor, it activates the complement system. And I see the complement system like a snitch. The complement system will activate a whole cascade of immune cells, and will tell them, hey guys, come down here. Let's kill this muscle membrane. So once this binding occurs, it activates the complement system. The complement system now calls all this army of immune cells to kill or to destroy the muscle membrane. On the right side here, we see a muscle membrane that is now less functional. The deep folds here have now simplified. They're not as deep. And now that reduces the number of receptors. You can count, there's a lot of receptors here. And this side here, there's less receptors. And those receptors are not working well. So the immune system, the complement system, calls bad cells to come and attack the membrane where the receptor lives. What Soliris or Ultomiris, what they do is they bind the complement system. So when the myasthenia antibody attaches to the receptor, now these complement system, they are shut up. The Soliris prevents them from calling all those bad guys to attack the muscle membrane. And that's how Soliris and Ultomiris work. Notice that they work at the complement level. So they really do not reduce your cells, your B cell ability to produce antibodies, to produce myasthenia antibodies. As such, they don't lower your immune system, and they can even be used in combination with immunosuppressants. Briefly on these, they're both IV. They have the same mechanism of action. The efficacy between those are the same in the clinical trials. The difference is on the dosing. Soliris is every 2 weeks after an initial induction dosing. And then Ultomiris is a longer acting one. It's done every 8 weeks. There's really no reason why to be on Soliris when you can be on Ultomiris. The efficacy and the mechanism of action is the same. They're both for adults, seropositive and generalized myasthenia gravis, and they both require a meningococcal vaccination 2 weeks prior to treatment. Vyvgart. Now let's talk about Vyvgart. To understand how Vyvgart works, we need to know about the concept of IgG recycling. As you remember, our plasma cells come from B cells. They produce antibodies. Now, those antibodies, they don't live forever. They're around for about 14, 21 days in our bloodstream. And while they're around our bloodstream, if they're good antibodies, they protect us. But if they're bad antibodies, they're attacking our neuromuscular junction. In about 2 to 3 weeks, these antibodies are removed from our body. And how are they removed? There's a cell called lysosome, and the lysosome will degrade it. It will eat them. It will melt it down. But it will not eat all of our IgGs. Some of the IgGs will have a second chance to live and go back into circulation. And that's called IgG recycling. And I've created this so it's easier for you to understand here. Up here is this is a blood vessel. In our blood vessel, this is just our bloodstream. We see here that we have 8 IgGs. 2 of them myasthenia, and the other one's normal IgGs. Okay, and it's been 2 to 3 weeks, so now it's their time to die, go away. The way this happens is our cells, this is a cell of the body, it could be a cell from this lining right here. Our cell will take those 8 IgGs into a endosome here. And once they come in, they will play musical chairs within this endosome. And the chairs are called FcRns. And some IgGs will find FcRns, and some of them will not find FcRn. Those that are unbounded to the FcRn, those that could not find the musical chairs, they will get degraded or eliminated, eaten by the lysosome. Now, those 4 that actually found the FcRn, the musical chair, they will get a second chance and they will get thrown back into our circulation. Now, that's fantastic because that's a way our body prevents us from not having enough IgG. Now we have a lot of IgG. Even when we're immunocompromised temporarily, our body is not eliminating all of our IgGs. But if you have myasthenia gravis, you do not want your own body to throw back the bad antibodies into your circulation. You really want to get rid of all of these bad antibodies. So that's where VYVGARD comes in. What VYVGARD does is, once these 8 antibodies right here, IgGs, once they come into our endosome, once it's time to find the musical chairs, these chairs will be occupied by VYVGARD. VYVGARD has a higher affinity to these FcRn receptors. It will attach to them before these IgGs attach to them. So they will occupy the majority, not all, but the majority of these FcRns. So now, more IgGs are unbounded, more IgGs are free. And remember, all the IgGs are free will get eaten away by the lysosome. And the ones that get bounded, this lucky one, he gets thrown back into circulation along with some of the VYVGARD. That's why VYVGARD it's a long acting. And that's how VYVGARD works. It binds to the Fc receptor so that the antibodies, both the good and the bad, so that the IgGs do not get recycled and they don't and they go and die into the lysosome. Notice that it does not eliminate all of the IgGs, the majority, but not all of them. As such, it does not suppress completely our immune system. Also, it only affects IgGs, so all the other IgGs are not affected. All the other IgGs, all the other immunoglobulins, the M, the A, right? All of those are intact. Okay, so our immune system would not be compromised with VYVGARD because it does not eliminate all of the immunoglobulins. It will eliminate the majority of IgGs. It is approved for adults, seropositive, and generalized myasthenia. It is also an IV medication, and it is once a week for 4 weeks, and that constitutes a cycle. Once you complete a cycle, then subsequent cycle will be on an as-needed basis. And that varies between patients. For some patients, they will need a second cycle in 2 months. For some patients, it will be in 3 months. For some patients, it will be more. So that it varies between patients. There's no vaccination needed prior to each treatment. And some of the most common side effects are headaches. There were reports of respiratory tract infections and urinary tract infections. Now let's move on to, we just completed the immunomodulatory treatment. Now let's move on to the emergent treatment. And this is plasmapheresis and IVIG. And plasmapheresis is not a medicine, it's a process. And basically you get hooked to a machine and your blood will go into this machine. And once it's inside that machine, it will centrifugate, which this is what it looks like. It spins around really fast. And once it spins around, it will divide your blood into plasma and cells. The plasma gets thrown out and the cells go back into your body. This is how it looks like when it comes out of the centrifuge. Down here you have the cells, and up here you have the plasma. Why is it so important to get rid of this plasma? Because in that plasma, that's where the MG antibodies live. So mechanically, you are removing the IgGs, the myasthenia antibodies from your body. And that's how plasmapheresis works. It removes the antibodies, the bad IgGs, the myasthenia antibody, it removes them. How? By removing the plasma from your body, from your blood. And removing the antibodies translate to less neuromuscular junction blockade, so that improves strength. Plasmapheresis is very effective, in my opinion, one of the most effective treatments. And typically every other day for 5 treatments, and the onset of improvement is variable. Generally, after second or third exchange, we start seeing an improvement. Now, this is short-term improvement. Okay, that benefit will wear off after several weeks. So there has to be a backup plan when you're doing plasmapheresis, a long-term backup plan, because plasmapheresis is short-term treatment. It's indicated for MG exacerbations, crisis, also for surgical pre-op, and an exception is not the rule, but sometimes some patient will need plasmapheresis as a chronic management. Again, the standard dosing is 5 exchanges. You could do more depending on certain things that we look into. You should not get plasmapheresis if you're actively infected, if you're septic, okay, if you have a fever, if you have a low blood pressure. Some of the side effects of plasmapheresis are complications from the central line placement and complication from the procedure itself. Some institution uses a central line, some institution do it peripherally. If you get a central line, the needle can collapse your lung, or you can get infections in the line, or even cardiac arrhythmia from the tip of the line tickling your heart can cause an arrhythmia. If there are complications from the procedure itself, includes low blood pressure and bleeding. IVIG. IV means intravenous, so the treatment goes through your vein, it's not all. And IG are immunoglobulins. So these are intravenous immunoglobulins. Immunoglobulins are antibodies, IgGs. And a bottle of IVIG, like here, hanging here, that comes from the plasma of thousands of donors. Okay, and they make up this super concentrated collection of antibodies. And this is how it works. This right here is your nerve. This down here in blue is your muscle. And these red things here are your receptors. And these smiley faces are the acetylcholine vesicles. Okay, so as we've discussed before, the acetylcholine reaches the receptor, and once it reaches the receptor, a contraction occurs. Okay, now we have our B cells in our bloodstream, and they're making the good IgGs in orange. However, this B cell is confused and it's also making the bad reactive antibody or autoantibody, the myasthenia one, in teal. When you get IVIG, this is what happens. The IVIG will bind, it will prevent, okay? It will avoid, hopefully, those bad antibodies reaching to the target, which is a receptor. So that's part of how it works. It will bind these, it will prevent the bad antibodies to reach to the receptor. In addition, you guys remember that complement that we talked about, this niche that tells our immune system, hey, let's come and attack our muscle membrane. Well, IVIG also binds that guy. And that's how IVIG works. It binds the bad antibodies so they don't reach to their target. And it also inhibits the complement activation. IVIG is also short-term treatment. It wears off after a couple of weeks, so a backup plan is also needed. Also indicated for exacerbations and crisis. It can be used for surgical preparation if someone's a poor candidate for plasmapheresis. It's not typically used for chronic management, but it could be used in, again, as an exception, not the rule. Let's say someone has contraindication or refractory to all of the other immunomodulatory medications. And the dose depends on if this is the first time you get it or if it's more a maintenance dose. The dose will depend. IVIG is used on a number of neuromuscular diseases, but it's also used on other autoimmune diseases as well. You should be checked to make sure that you do not have IgA deficiency. If you have IgA deficiency, you can have anaphylaxis with IVIG. Anaphylaxis is a bad allergic reaction, potentially life-threatening. It can also cause CV. It's also contraindicated in someone who has kidney disease. And that's because IVIG is a large solute, and that can cause problems in your kidneys. Also should not be used in patients who have cardiomyopathy, a big heart, which a weak heart. And that's because IVIG is a large volume, a lot of water, there's a lot of volume that goes in. So your heart needs to pump more. If you have a weak heart, that can lead to pulmonary edema or water in your lungs. Side effects, there are severe side effects that can occur, like anaphylaxis. That could be potentially life-threatening. Renal failure, as we mentioned, it can cause thrombotic events, things like stroke, okay, heart attacks, etc. It can cause embolic arterial embolism to an arm. You can lose an arm. Okay, it can cause meningitis. And there's also some infusion-related reactions like headaches, hive, nausea, flushing, vomiting, etc. Some of the infusion-related reaction can easily be treated with reducing the infusion rate, just making the IV goes down slower, and also the use of pre-medications to avoid headaches and nausea, etc. There is also subcutaneous IG called Hizentra. That's not approved for myasthenia gravis and currently is in investigation. There are several clinical trials and open trials for Hizentra. So hopefully, maybe in the future, it will be a FDA approved option. But for now, it's FDA approved for other neuromuscular conditions, but not myasthenia gravis. And this is the last slide. And this slide shows pretty much all the MG treatments throughout the mechanism on the pathophysiology or the different mechanism of how these medications work in this cascade of areas that we can treat myasthenia. So let's start from the right side. here at the neuromuscular junction, this is where Mestinon or pyridostigmine Mestinon works. It's not here, it should be, but it's not here. But this is where Mestinon is working. Okay. Moving now to the bloodstream, we have the myasthenia antibodies, and these could be mechanically removed by plasmapheresis, or they can be bound so that by the IVIG, so that it prevents it from reaching the target. Also in our circulation, we have the complement, and the complement is the one that calls our immune cells to go in and attack our membrane. That complement can be shut off by Solaris right here. Also, in our bloodstream, we have our immune cells. Our immune cells can be reduced with medications like mycophenolate, Celsep, or Imuran. In addition, remember in our B cells, we have this, in the surface of our B cells, we have the CD20s. CD20s is the jockey of the horse, moves the B cell around. That one right there can be blocked by Rituximab. Also here we have remember the FcRn, which is the musical chair. That recycling of IgGs into our bloodstream can be inhibited or prevented with efgartigimod, which is Vyvgart. Finally, all of our bloodstream, all of our blood cell lines comes from different immune areas in our body, including our bone marrow and thymus. So that's why thymectomy can also help as part of it's also part of the treatment of myasthenia. And that's it. Thank you very much.
Thank you, Dr. Rosario. We've got a lot of good feedback. Excellent. We do have some questions, Dr. Rosario, and I want to be mindful of your time because I know you have another meeting. So I'm going to kind of generalize questions so we can get them in groups. How long can you be on an immunosuppressant like Imuran? Can you stay on it the rest of your life?
If you need to. Ideally, our goal is to have you be on the best you can be with the least amount of medication. If you're on Imuran, obviously you're being monitored, you're being examined, okay? And there are some tools that we use in clinic to monitor progress. And once you're better and that improvement is sustained, then we want to start tapering your medicine slowly, cautiously, judiciously over time, and continue evaluating you and see what's the least amount of medicine or treatment that you need to keep you at that decent level. And that might be some form of immunosuppression or immunomodulatory medicine forever. Some patients were able to taper everything away after some time.
What medications are best used for extreme fatigue?
Well, that's a different off topic. Fatigue in myasthenia, you will get muscle fatigue, but fatigue can occur for many other reasons. Things like anemia, vitamin deficiencies, hypothyroidism, sleep apnea, etc. So just because you have myasthenia, you cannot just say that the fatigue is from the myasthenia. You need to have a medical workup to see if there's anything that can be treated. Let's say you have apnea. Well, getting that treated might help the fatigue. Now, if the muscle fatigue is from myasthenia, meaning you're using your muscles and you're getting all tired, generalized weakness from activity, then treating the myasthenia should improve the fatigue.
I have two more kind of generalized questions too. What is available for, and we knew this would come up, seronegative patients besides prednisone and Mestinon?
Well, all of the discussed treatments except for Soliris, Ultomiris, and Vyvgart. So Imurin, Cellcept, Mestinon, Prednisone, Rituxan, IVIG, plasmapheresis. They can all be used in seronegatives. Hopefully in the future, hopefully near future, we can use Vyvgart in seronegatives. In their clinical trial, seronegative patients were used. As such, there is a chance that the FDA will approve it for seronegatives, as opposed to Soliris, where seronegatives were not included in their trials. So it's less likely that that medicine be approved for seronegatives in the future.
Thank you. How about research being done on cannabis and MG? Have you seen anything?
Oh, me personally, I have not seen it. I haven't looked into it either. So I am not aware of any research in that field. However, I have not looked into it either. So I don't know if there's any, research going on with cannabis.
Okay. I know we weren't talking about thymectomy, but a question came up. If somebody is seronegative, cannot take an immunosuppressant, is thymectomy then a viable option? Can you explain what would make that a viable option?
So if you have generalized weakness, generalized myasthenia gravis and seronegative, it is. If it's only ocular, or if it's generalized but mild, then thymectomy might not be appropriate. It's an invasive treatment. It's a surgery, and yeah, would not use it if you only have mild symptoms. Will not recommend plasmapheresis for ocular myasthenia. Or if you have well controlled, let's say you have generalized, but with initial treatment, now you're doing very well. You're only on Mestinon monotherapy, maybe on an as-needed basis, and you're doing fantastic. You do not need a thymectomy.
Okay, we had a question come in, and sometimes we forget, those of us have been on the journey for a little bit, that we do have new people joining, and we want to make sure we educate them. Can you please explain what seronegative means, and why would somebody not take Vyvgart?
Sure. Some patients with myasthenia gravis will have the presence of acetylcholine receptor antibodies in their bloodstream. Not everybody. It is believed that about 80% of patients with generalized myasthenia gravis will have presence of acetylcholine receptor antibodies in their bloodstream. That's a blood work that can be done at LabCorp, Quest, etc. If a patient with myasthenia gravis tests negative for those antibodies, then they're considered seronegatives. With time, we have find out that there, of course, there's other antibodies that causes this condition, but technology hasn't, we do not know all the antibodies that causes myasthenia. We've identified one called MuSK, muscle-specific kinase, MuSK antibody. And there's another one, the ALRP4, that's a newer one. We're testing for those now. Still, there's patients that test negative for acetylcholine receptors, MuSK, and LRP4. So if you don't have the presence of an identifier, any of those, then you have seronegative myasthenia gravis. And the reason why some of these medications are approved only for seropositive is because during their clinical trial, the majority or only seropositive patients were allowed to participate. Seronegatives either were not allowed or they constitute a smaller percentage of the patients that the medication was studied on.
Thank you. If anybody has any questions, we could probably take one more. Hold on, I have one more. Dr. Rosario, this is, I think the highest compliment you got was the best presentation they've seen in 50 years. So
Thank you.
thank you so much for that. Somebody wanted, well, and this is an objective, is Vyvgart better than Mestinon?
Well, they're
Subjective.
different. If you're doing well with Mestinon, okay, then you should not, then Mestinon is better than Vyvgart. I mean, you want to start with Mestinon. As a reminder, Mestinon does not have long-term side effects. Mestinon is relatively cheap. Vyvgart is very expensive. Vyvgart is IV, and it has side effects. Mestinon is cheap, is oral, and does not have long-term side effects. So from a side effect perspective and from a accessibility or access, Mestinon is much cheaper and easily accessible. Now, at the end of the day, we use what works. So we start with Mestinon, and if Mestinon helps, if Mestinon achieves our goal, then we really don't need to go beyond that. If we use Mestinon and we're still having symptoms, that's when we go to tier 2 or phase 2. That's when we start adding some of the other ones, and Vyvgart is one of the options. Thank you very much, everybody.
Thank you, Dr. Rosario. That was truly a very great explanation, very clear for us. And as Dova put in the chat, this will be available on myasthenia.org. So you can go back and re-review it if you would like to. And we really appreciate your time, Dr. Rosario.
Thank you, everybody. Happy to be here.
Now, I'm going to introduce Dr. Elizabeth Liz Plowman. She's the owner of the Pain Boss Physical Therapy and an assistant clinical professor at Texas Woman's University School of Physical Therapy in Houston, Texas. She began her career as an active duty physical therapist in the United States Navy. In 2019, she was medically retired from the Navy due to a disability related to myasthenia gravis, at which point she opened her own private practice and joined the faculty of Texas Women's University School of Physical Therapy. Dr. Plowman is a board-certified orthopedic clinical specialist and a therapeutic pain specialist. She is dedicated to the successful integration of technology into rehabilitation practice, improving access to care for patients with disabilities, and helping to move the profession forward into today's tech-savvy world.
Thank you so much. I am so pleased and honored for the invitation to be here today, and to be able to see you. I see some familiar faces out there, so nice to see you again. And thank you very much, Donna, for the wonderful introduction. I am actually, I'm going to go ahead and share my screen so I get some slides going here for you. But I am very pleased to chat today, hopefully this comes up, about exercise with myasthenia gravis. There are going to be some subtitles here, so for those of you who need the subtitles just to help with a little bit of accessibility, that's there for you. My disclaimer is that it is entirely voice recognized, and sometimes PowerPoint does not get all the terminology correct. So that's my disclaimer on the closed captioning. So just a little bit about me. Of course, you just heard a good deal in that introduction there, and thank you again for that. So I am a physical therapist. I am board certified through the American Physical Therapy Association in orthopedics, also in pain science education, and most recently, I've done a specialty training in neuromuscular disorders and rehabilitation for that, because of course it's very personal to me. I was an active duty therapist in the United States Navy. Working with a wide variety of folks. I am now in private practice, working with chronic pain conditions and neuromuscular disorders, specifically myasthenia. Honored to be on the faculty at Texas Women's University and doing research with them into myasthenia and rehabilitation implications and exercise implications, which is fueling a lot of this presentation today. And then I think I'm branded on the internet as the myasthenic PT. So that is me. That is my little story in pictures here. As a disclosure, I have nothing else to disclose, and I do want to acknowledge I have a fabulous group of research students at Texas Women's University working on the projects that I previously described, and they have helped contribute to the content of this presentation. So I do want to acknowledge them. So coming up, we're going to talk about exercise. So what is it? We're going to talk about the health benefits, MG concerns with exercise, and then of course, how to exercise safely in the context of myasthenia. So this is working with any of the myasthenics that I have ever worked with before. This is probably the universal question that I get is, can I exercise with myasthenia gravis? And the answer is yes, with the asterisk mark that there are some very special considerations with specific to myasthenia that is different from just about every other condition that might limit exercise. Yes, exercise is absolutely possible and there are wonderful health benefits from it, but it has to be approached carefully and likely with direction to avoid any of the complications from myasthenia. So in using the word exercise, exercise can sometimes be a rather intimidating word. And a lot of times when we think of the word exercise, certain images come to mind, most likely something like that, right? But that is not, that is a type of exercise, probably not one that the vast majority of us would be engaged in. But exercise can mean a lot of different things. So it can be walking, gardening, swimming or water type aerobics, which I will talk about a little bit more in this presentation. Yoga, Pilates, stretching, Tai Chi, and things in that family are wonderful forms of exercise and movement. Aerobics, stability, core training. I am from Texas, so I'm obligated to put some dancing in there. And then just simply things that we aren't necessarily organized exercise, but spending time playing around with kids, pets, grandkids, things that require just a little bit of activity there. So maybe instead of exercise, even though I'm going to use the word as we go through, think instead of, if that word evokes that very first image that I put up there, the heavy weightlifting, and that's an intimidating word, instead of thinking exercise, think of activity, think of movement, all of which are vital to a relatively normal quality of life, to doing activities that are important to us, and then also to staying healthy. So health benefits, and I'm going to go fairly quickly on this slide because I'm probably telling you nothing that you do not already know. So there's a mountain of health benefits related to exercise in general, not even talking about MG yet, but just in general. And the research that supports physical activity for health benefit is staggering. I could probably, if I had listed every single reference that talks about the health benefits of exercise, I think I might have blown up PowerPoint. So health benefits, it prevents deconditioning. So deconditioning is where, after prolonged sedentary time, you get muscle atrophy, and you get various cardiopulmonary related issues too, just related to being deconditioned. Exercise improves cardiopulmonary health, and heart disease, as a reminder, is one of the biggest killers in our country, and it is the leading killer among women. So cardiopulmonary health is understated, but so very important. And exercise is one of the best things to improving cardiopulmonary health. Mobility and function. So, and now we're getting into MG, right? So being able to move, being able to do your daily tasks, things that are important to your life, all of the ing words. So dressing, eating, bathing, generally functioning. Balance and stability. You have muscle tone is required for that, and then that leads into decreasing fall risk. Improving metabolism. The physical activity is probably one of the best things to do to improve metabolism. Bone and joint health, especially as we age. Bones and joints require loading in order to maintain good health, which requires physical activity and movement. And there's a lovely batch of chemicals that get released by the brain. Serotonin to probably to be number one there, which will improve mood. So lots and lots of health benefits to exercise. But there's always the but, right? There are exercise concerns with myasthenia gravis. So MG symptoms are exacerbated by repeated contraction of affected voluntary muscle fibers. So voluntary muscle fibers are those types of muscles, skeletal muscle, things that you think about, okay, I want to voluntarily move. If you can voluntarily move it, you're likely talking about a skeletal muscle. Some of those are, of course, more affected in myasthenia than others. So the ones that tend to be closer to your trunk, so shoulders and hips, tend to be a little bit more affected. Ones that are further away, so hands and feet, tend to be less affected. But that being said, myasthenia can affect any voluntary muscle in the body. So you have your the nerve signal. So the nerve sends a signal, releases acetylcholine, and I'm glossing over this because this is, of course, information you've already received. But acetylcholine releases at the neuromuscular junction, and with that repeated voluntary contraction of muscle fibers, if you kind of get enough of that, with myasthenia being that autoimmune disorder, those anti-acetylcholine antibodies are going to be released, and then that communication between the nerve and the muscle is impaired, and so that muscle firing becomes impaired. Excessive muscle firing demand can lead to an increase in those MG symptoms, and then if you keep going, of course, that can cause flare-up or even crisis. So typical exercise regimes, exercise instructions are generally not compatible with the presentation of myasthenia. So things like push through fatigue, pain is no pain, no gain, more is better, feel the burn, those sorts of things. Those probably exercise instructions that we've had drilled into us for all of our lives. I mean, think back to junior high PE classes. That type of approach to exercise does not work with myasthenia. That is where we can run into some danger. That is where we run into some caution, because now we're basically causing that cascade of anti-acetylcholine antibodies to be released, decreasing that muscle performance, and then you can have an increase in symptoms. And then where it really gets dangerous, of course, is where you start losing that connection, the communication to the diaphragm, and you start having impaired breathing. So I do want to put that out there, that these are the big exercise concerns with MG. However, we have to kind of sit here and weigh, right? There are benefits of exercise, and there are health risks if you don't move and you don't exercise. And then there's a practical issue where you need to live your life, and that requires being able to move around. That requires being able to lift and carry. That requires being able to do functional things. So we're kind of sitting here with a balance. So what does the research say? There's within the past decade, there has actually been some decent research done on physical activity in myasthenia gravis. And I've pulled out some of them. There are more, but these are some of the highlights. So there were 2 papers by Westerberg et al. And between the 2 of them, they concluded physical exercise in MG is safe. And it does improve neuromuscular parameters and physical performance-based measures. So they found that in their study. Wong et al. Found that specifically doing balance strategy training will improve balance and decrease fall risk in patients with MG. Van Heusen et al. In 2020 determined that an independent exercise program will improve community participation. So being able to do things out in the community and interact and such like that in patients with neuromuscular disease. And they actually broke it up, and they did look at subsets of various neuromuscular diseases, and MG specifically was one of them. And then Ziska et al. Found that directed exercise programs with neuromuscular disease is safe. And that was another one where, of course, they broke into the different categories of neuromuscular disease, and MG was one of those. So the research shows us that, basically to sum this slide up, that directed exercise in MG with considerations of the disorder is safe and has those health benefits that we talked about. So how do I find the middle path between staying safe with MG and reaping those health benefits, and on the converse side of that, not having those deleterious effects of not exercising or not doing physical activity? Well, the good news, yes, there's a middle path. So very specific exercise considerations for MG. So things to think about. First and foremost, and I'm going to sound like a commercial, but please consult a healthcare provider before engaging in exercise or physical activity beyond what you currently do. So if you are already participating in an exercise program, or you have a certain level of physical activity and you're controlled and you're safe in doing that, please continue doing that. But if you either are not engaged in an exercise activity plan and you want to be, or you want to up where you are, because of MG, I highly, highly recommend that you do consult your healthcare provider. This is possibly a little shameless plug for my profession, but consider working with a physical therapist. And specifically those, this is a little lesser known in our field, but physical therapists specialize just like other professions do. So there are physical therapists specialized in neurology. There are physical therapists specialized in orthopedics, or both, as the case with me. So you want to definitely work with one who is specialized in neurology and neuromuscular disorders. You want to consider your symptoms. So your MG should be reasonably well controlled, and that would be a determination that between you and your neurologist. Likely with medications, of course, some people do go into remission, which is fabulous, but the vast majority of us are on some sort of a medication. So you want, like I said, work with your neurologist to make sure that your symptoms are reasonably well controlled before starting or increasing exercise. You want to exercise or engage in more strenuous physical activities when you're at your best. So 3 things to think about. 1, time of day. Think of the time of day when you tend to be at your best, your energy levels at its peak. So for most people, this tends to be on the earlier side of the day than the late, but perhaps maybe not first thing in the morning. Again, it's going to vary from person to person. But for me, I'm just going to use me as an example. My peak time of day is 10 a.m. And so try to plan and budget. If you're going to have a more strenuous physical activity, try to plan and budget it at that time of day where you're going to be at your best. Also think about medication timing. So if you happen to take something like Mestinon or pyridostigmine bromide, the non-extended release one. So they're usually 60 milligram tablets and taken as needed or every 3 to 4 hours typically. So think about your medication timing. So that generally takes around about half an hour or so to kick in. So you want to plan basically to plan your exercise, maybe 30 minutes to an hour after you have taken that Mestinon dose, so that you're getting the best effect of it. And then also, and I think this is particularly pertinent right now, while the majority of our country is baking, avoid overheating. So especially in summertime, that's going to be a lot of indoor activity, especially if you are, like I said, I'm hailing from Houston, Texas right now, and I think we're very excited. This is our one day of not having a high over 100. So those outside exercise activities can be particularly dangerous. So definitely avoid overheating. Pool exercises, you want to go in a cooler pool. So, you basically want to stay under 90 degrees in the pool. Closer to 85 is actually better, but so those are considerations there. Let me go. Things to avoid. All right, so you want to avoid repeated contraction of the same muscle group. So this photograph down here of the guy doing the bicep curl, so that same bicep curl, 10 reps, 20 reps, 30 reps, that's repeated contraction of the same muscle group that you want to avoid. You also want to avoid sustained muscle contraction. So that's basically where you contract the muscle and you hold it for a long period of time. There's a lot, certain types of yoga do a lot of sustained muscle contractions, which can be a little tricky in MG. So instead of that, we can perhaps think about doing a circuit. So instead of doing the same contraction of the same muscle group, you might do, for example, a bicep curl and then an overhead press, and then maybe lift up on the tricep. So you're using different muscles, but you're kind of cycling through them. That's a way that we get around that. And then how we get around sustained muscle contraction is, and I'm going to harp on yoga a little bit, just because that's probably the best example that most people are familiar with. So instead of holding that tree pose, for example, or holding the downward dog pose, I like to do yoga flows, where you flow through them, go from one position to another, to another, to another, so that you are getting the benefit of the movement. The muscles are contracting, so you are using them, but you're not overly contracting, so you're kind of trying to stay under that threshold of where the autoimmune characteristic of MG is going to kick in and start releasing those anti-acetylcholine antibodies. You also want to avoid too much too fast. So if you are at a if you're at a certain level where a walk around the block might be as much as you do, and I'm only using that as an example, so please don't think that that's a baseline. Some people may be way above that. Some people maybe a walk down the driveway is what is normal for you. But think about where you are. So if a walk around the block is your thing, running a 5K is going to be too much too fast. So you want to gradually increase, making sure that you're staying at a level that is comfortable, that is safe. You also want to avoid what I like to call pushing through. And so that's where you start feeling muscle fatigue. And again, that's going back to going against all the things we've been taught, right? We've been taught you want to push through muscle fatigue because that's where the gains are. That's not true. And it can be potentially dangerous. You can start having increased symptoms in MG if you start pushing through muscle fatigue. And then also keeping up with others. And I want to put the caveat in here, keeping up with yourself, because for a lot of us, we developed myasthenia at some point in adulthood. And so prior to myasthenia, we may have had an increased level of fitness. So speaking personally, right, I was active duty in the military. I was very physically active, and I was deployed on an aircraft carrier, and we had a exercise group. We'd go run on the flight deck, and we would do the insanity programs up on the flight deck. And post myasthenia, that level of activity may or may not be attainable. And it certainly, if I set that kind of bar for myself, or trying to keep up with myself or what I was pre-MG, I'm potentially setting myself up for failure. So, so keeping up with others, remember, we are all, people with myasthenia are all at different points in the disease, and we all have different levels. So, so just caution with that. All right, so here's some of the how-tos. And so I've touched on this a little bit in that first slide, but so exercising safely, start ridiculously easy. And I mean, absolutely ridiculously easy. If you're already at a certain level, let me put this caveat in there. If you were already exercising and you already have a safe, nice, comfortable level, that is where you start. If physical activity is not part of your normal life, you want to start with something that you absolutely know that you can attain, because you know that you're going to be safe at that level. Okay. And then you start ridiculously easy, and then you start low and go slow. So you increase, once you're comfortable at a certain level, then you might increase just a little bit. So for example, if you were comfortable walking or riding, let's say riding a bicycle for 10 minutes, if that's where you're comfortable, then after of course rest, the next time you try that activity, if you were very comfortable at 10 minutes, the next time you might try 11. Because it's a small incremental increase, but likely one that is going to still keep you under that muscle fatigue threshold, under that autoimmune firing threshold, and it's going to be something that is safe and attainable for you. You want low impact and low resistance activity. So you want good movement, but you want to be easy on your muscles. You want to basically get the best bang for your buck without causing a lot of that muscle fatigue, or that excessive use of affected muscle. So that's going to be achieved through some low impact and low resistance activities. Low reps, low sets, frequent rest breaks. So the American College of Sports Medicine talks about when we dose exercise or prescribe exercise, depending on what your goal is, right? There's, do I use high weight or low weight? So the traditional recommendation is that if you're trying to increase strength, you want to, or increase muscle bulk or power, you want a higher weight or higher resistance with lower repetitions. And then on the flip side of that, if you're trying to increase endurance, you want low resistance with higher repetitions. Well, both of those are, they kind of go against the initial MG exercise guidelines. So there's a study done that looked at doing low resistance and low reps with frequent rest breaks in myasthenic patients, and they did ultrasound imaging of the muscle, and over time, it was about a 6-month course, they were able to see an increase in the width of the muscle, which indicates that there's muscle hypertrophy, which basically means that muscle's bulking up in layman's terms, and there was an increase in strength. So so the low reps and low weight with frequent rest break, it takes longer than the quote unquote traditional exercise prescription, but the research shows that it is still effective and it's safe with myasthenia. No extra weight is required unless you are already at a level where you might be lifting weights or having some extra resistance. If you're just getting started, no extra weight is required. Simply by raising a limb against gravity, that is, you have the weight of that limb plus or times the distance of that limb from your trunk, and that is sorry, I'm bringing physics back here, so let me get off of physics. But basically, that is enough resistance, and that is enough work on that muscle. So you don't have to lift heavy weights to get the muscles to work. The weight of the arm or the leg is perfectly adequate. Swimming or aquatic exercise is fabulous with myasthenia, with caution, of course. So you want to stay in shallow water where you can touch the bottom or hold to the side. Flotation aids are very helpful too, because the danger with water is that it is deceptively easy, and you will actually, you can't feel that the muscles are fatiguing until then they either quit working or you get out of the water and then you really feel it. So you can get a lot more work done in the water because you don't have as much strain on the muscle. And so you can basically stretch what the muscle is going to be capable of before that myasthenic muscle fatigue. But sometimes that easiness of the water can mask that muscle fatigue. So safety considerations there: shallow water, flotation aid, and then also, it's not on the slide, but don't be alone either. So those are some cautions with that, and then cooler water too. Cycle through movements and body regions to prevent excessive fatigue. I touched on this on the previous slide. So that you're still getting movement, but you're basically giving different muscle groups rest as you move through. So with MG, I love circuits, so I love a little bit exercise one, maybe the arm, and then do a exercise down on the legs, and then maybe do something for core stability, and then cycle through. So you're getting work and you're getting endurance there, but you're not excessively fatiguing any one region of the body. And then, most important, stop before you feel tired. So rest before you think you need to. And so these are my guidelines, research-based, for safe exercise with myasthenia. And then the stop before you're tired, that's going to lead me right into this rate of perceived exertion scale, which is very, very important with any exercise, but specifically with myasthenia. You want to kind of keep a feel on where you are on this scale as you are exercising or doing physical activity. And with myasthenia, I say stay in the green. So 1 is a very light activity, basically anything other than just completely lying flat in bed. 2 and 3 is light activity. And one reason I love this scale is because with MG, breath is a very important thing. And this talks about what your breath feels like. So it should be very, very easy to breathe. You can carry on a conversation if you're doing levels 2 to 3. 4 to 5, you could still do the activity for a longer period of time, and you can talk while you're doing it and be able to hold short conversations. And that is, for MG, that is where you want to stay. You want to aim to be in that 4 to 5. Beyond that, that is where you are on the verge of becoming uncomfortable. You start getting short of breath. You can maybe get a sentence out. You start getting breathy. That is where you need to scale back your activity. So this is a really, really important scale. And then, of course, please don't get into the orange or the red. So I go for green with this particular scale. It's called the rate of perceived exertion scale. Some resources for getting started. I'm going to acknowledge my research students at Texas Women's University. They put together a research-based exercise, some exercise videos. So the link is here. The link is on the slide, and I believe this presentation is going to be available. But if you just go and search on YouTube, Safe Exercise with MG, this video series should come up. It is from Texas Women's University. It has 3 exercise videos where they go through all of these basically exercises and exercise variations. So sitting and standing, easier and harder, specific to MG. So exercise flows, lots of rest breaks, and there's a safety video in the beginning, which reiterates a lot of what I talked about. And then the very last video in the series is yoga. So they go through a couple of different yoga flows where we're cycling through different activities. So I was really pleased with my students. They did a lovely job, and they're actually they're presenting a poster on this at a research conference coming up next February. So I'm really excited about that. But great resource if you're getting started or just need some considerations for exercise with MG. So these are some of my references. And these are my children. My daughter, when she was in this picture, she was about 10 months old in this picture. She could do better push-ups than I ever could. So these are my little ones. And then this is me. So if you do need to, please feel free to reach out, contact me. I am more than welcome to entertain any and all queries to help you be more physically active.
Thank you, Liz. We've got several comments about the fact that you have motivated people to seek out some more exercise now that they know the right way to do some of that.
Yeah.
And a few questions. For us with MG, is light weights or resistance bands a better option?
It depends on what you're doing. So either are fine. But I would be honest, if you're just getting started, I would try the movement with nothing at all. Just the weight of the limb against gravity to start, like I said, start ridiculously low and slow. Lightweight is fine, and lighter resistance bands are fine too. You're just kind of working different muscle groups. The difference with weight is that you're going to have a sustained resistance throughout as you complete the movement. With resistance bands, it's of course going to get easier and harder at different points in the movement. There are benefits to both there, so I guess it really depends on what you're doing. But if you stay with either are fine, but if you stay with that start low and go slow mantra, you'd be fine with either of those. So the lighter colors on the exercise bands. So yellow universally tends to be pretty easy, and then it kind of goes up from there. Where blue and black are up toward the hardest, and then lighter weights. But yeah, start low and go slow.
If I can exercise one day, but the next day I end up barely being able to do anything, is that normal? Am I doing too much?
That is not normal. You are doing too much. So that means that you need to basically whatever level you were at on the day that you did exercise. If it's causing you to be completely wiped out later that day or the next day, that was too much. So I would absolutely scale back whatever it was you were doing. And that goes back to my start ridiculously easy. So if you think what you're doing is easy, go easier than that, and make sure that it is safe and it's sustainable for you, and that you are not wiped out the next day. And you'll know that that's a good, safe baseline, and that's where you start from.
Any tips to help differentiate between MG weakness and deconditioning?
MG weakness is going to fluctuate. So an MG type weakness will come on quickly. So for example, a muscle that is just generally deconditioned, you're going to have difficulty either doing the movement or maintaining contraction from the beginning. And then it will of course decline, but it'll be hard in the beginning. Whereas MG affected muscles, the first couple contractions you do are fine, and then you get a steep drop off.
Okay.
Which then recovers with rest. So that's really how you differentiate the two.
How do you choose any tips on how to choose a PT that's knowledgeable or willing to learn about MG?
So there are a couple of ways to do that. There are, if you go to the American Physical Therapy Association website, apta.org, and I'm not other than being board certified and a member, I'm not promoting them. There's a link on there called Find a PT, and you can search by various specialties. You can also kind of look around in your community, and basically search them out on the community. And a lot of times on their websites, they'll say, just like physicians do, they'll say, these are my areas of interest, or these are the things that I tend to treat. And so you want to look for neurology type, you want to look for neuromuscular. You might be hard pressed to find someone who specifically lists myasthenia. I do, but I'm strange. I'm a rarity in that, just because it is such a rare disease. So you want to look for more like the neuromuscular family. So you want to look for someone who's perhaps comfortable working with things like multiple sclerosis or Guillain-Barré syndrome or ALS, which it's different, but it's in the right family. And then also interview. There is absolutely nothing that says you have to, just take the physical therapist assigned to you. You should be able to call a practice and see if you can have a chat with the PT before you book with them. If the practice isn't willing to let you do that, I would find the next practice.
Is there any that you know of ongoing or current research or doing research about exercise and MG remission?
Specifically in MG remission, I am not familiar with any ongoing research right now. I personally have ongoing research in exercise with myasthenia. And there are some new studies that are coming out as it becomes a topic of greater awareness, but specifically of exercise in remission, I would have to go do some more research, but I am not familiar with anything right now at the moment. Most of the studies are either in well-controlled, which may include people in remission, or may include people who are essentially in medicated remission, if you will, or with a milder presentation of the disease. That's where most of the research has come, although there is some with moderate forms of the disease as well.
Cold therapy seems to be getting more popular. Is there anything that we should be aware of, or any studies being done on cold therapy and MG?
Cold therapy. So there have been some studies that have come out about basically doing resistance type training with cold packs, and that is getting some good initial review and initial feedback. But I think there's a lot more to be done. I'm not other than that one exercise study coming that's been going on. I'm not familiar with any others, although that's a great area for future research. So thank you for that little tip. I'm going to put that on my list for my students. Lucky them.
Muscle soreness. Do MG patients have any different delayed onset of muscle soreness over non-MG patients?
From the research, I can't speak to that because it's not an area that has been studied. However, anecdotally, in a lot of the clients that I have worked with, that is the overall report, is that muscle soreness may take a little bit longer, and also just post-exercise fatigue, like in the previous question where you're not necessarily wiped out that day, but the next day it really hits you. So post-exercise fatigue and post-exercise soreness, anecdotally, a lot of my clients tell me that they get they get sore, maybe even not the next day, but 2 days later is when they start feeling it, and then the time to recovery is more than that, kind of 24 to 36 hours. It's kind of more doubled than that, but to my knowledge, there's not been any formal research on it. Another great add to the list for my students.
What about relatively long distance slow walking, say 1 to 2 miles at a time every couple of days? Is that more beneficial than doing the faster paced?
It depends on your individual level. So that's not a recommendation that I could make blanket across the board, because someone walking across the house might be their limit. But yes, but generally speaking, kind of a lower pace, so kind of a lower intensity over a longer period of time certainly would be beneficial. Although if you do want to up that rate, basically there's kind of a changeover. So if you're going to go more quickly, or kind of do this interval, a little fast, a little slow, then you definitely want to shorten up your time. But just in terms of, for heart benefits, kind of the more you can be out and doing, the better. So if that is the exercise that is sustainable for you, if you can walk a mile or two, but at a lower pace, and you can kind of cover more mileage that way, then and do that safely, then yes, I would certainly recommend that.
What about using a personal trainer?
Same, certainly very helpful, but with my caveat that, just like with any professional that you're going to consult, you want to make sure that they're very knowledgeable about MG, and that they can work with the exercise considerations that are very specific to MG. So kind of just like, you wouldn't expect your dentist to help you with your MG. You wouldn't expect, right, a personal trainer who's never heard of it to be able to advise you there. So there are personal trainers who do kind of specialize in working with people with various disorders. So you want to find someone who is fully understandable of what's going on with MG, and they're not going to go that, push through, no pain, no gain. Come on, just do a few more reps and you'll get it stronger. If that's what you're seeing with a personal trainer, then just like with anyone that you'd be working with, that's a sign you want to change. But personal trainers, if they're knowledgeable and understanding, willing to work with MG, they have a good background in exercise science, and that would be a great resource.
And our last questions, what about massage and MG? Will that make my MG worse?
Again, I'm not familiar with scientific research on this topic, but massage in general should not increase MG symptoms unless it is a very aggressive massage where it's actually causing pain or discomfort, which causes you to contract the muscle as a kind of a muscle guarding, then that could potentially exacerbate MG symptoms, which is general Swedish massage without being overheated. So a lot of massage therapists like to warm their table up, which feels amazing. But if you have heat intolerance, that could be an issue too. So I would not have a heated table or heated blankets or things like that they do to try to make you comfy. And a general Swedish massage that does not cause muscle guarding, but without getting too diggy pokey, if that's not a technical term, but I'm going to use it, without causing pain that causes that muscle guarding. But otherwise, yes, massage, there's health benefits to it as well, and it's no reason why it should complicate MG.
Thank you, Dr. Plowman. That was a great presentation, and you got more than a few people motivated to start doing some exercise with their MG.
Fabulous. Well, thank you so much for having me. I'm truly honored.
And now we're going to take a break, guys.
We'll be back for Dr. Pulley's presentation at noon. So everyone stretch their legs, and we'll see you back here in 15 minutes. Thank you.
Pamela, can you hear me?
Yes, we can hear you. We're just gonna wait till the top of the hour to start.
I know, I just want to, so are you seeing the screen that shows the title slide and the others on the side?
Correct.
Okay, if I change it to
If you go to
this,
slideshow, we can still see your notes. If you go back,
no,
then on the top, like you're on design, if you go to slideshow and then do from current slide, right there. Yep. Oh, you still see, okay, that
I'm
works.
trying to, let me see something. I'm gonna try to change,
We can see your notes on the side.
yeah, I'm trying to switch these now and see if it
Good.
will work. Let's see now if I do it. From current slide. No,
No,
still seeing the notes.
yep.
Huh. Let me try. Same thing.
I don't see anything right now.
Okay, I'm trying to go.
Slides went to.
Where is my sharing option now? Where did it go to? Okay, share screen. Let me do this. I'll try screen 2. Share. And now I'm going to go to this from current slide.
So this works better than with the notes on the side. Oh, that's perfect. You
There
got
we
it.
go. We got it.
All right, couple more minutes and we'll begin.
Okay.
Thank you.
All right.
Welcome back, everybody. It's 12 o'clock, and our next speaker, and it's our pleasure to have Dr. Pulley with us. Dr. Pulley is an associate professor of neurology and director of the EMG laboratory at the University of Florida Health Science Center in Jacksonville, Florida. Dr. Pulley has expertise in diagnosis and management of neuromuscular disorders. He has a special interest in the management of myasthenia gravis and follows nearly 400 patients with MG. Dr. Pulley is also experienced in electrodiagnosis of nerve and muscle disorders and performs over 1,500 EMG and nerve conduction studies each year. Dr. Pulley has participated in clinical research trials for myasthenia gravis, Lambert-Eaton myasthenic syndrome, LEMS, amyotrophic lateral sclerosis, ALS, multifocal motor neuropathy, MMN, dermatosis, and chronic inflammatory demyelinating polyneuropathy, CIDP, and has served on the medical advisory board for the MGFA. Welcome, Dr. Pulley.
Thank you very much. Everybody can hear me okay?
Yes, we can.
Okay. So I'm just going to briefly recap sort of the standard treatments that are used for myasthenia very, very briefly. And then I'm going to talk about the new drugs that already are approved or are in the pipeline right now for myasthenia. And there's some that I won't touch on today because there's still like not any data available. I'm only going to talk about ones where there is data that's already available. Whenever we do a talk, we should give our disclosures that I have participated in some medical advisory boards for these companies. So just to let you know. Now, of course, at the neuromuscular junction, we have the antibodies against the acetylcholine receptor. But of course, there are other proteins right next to these acetylcholine receptors, like the MuSK protein, agrin, and antibodies against those are sometimes seen in addition to or instead of the acetylcholine receptor antibodies. And this is a really complicated slide. This is where the business of this happens here. This is the nerve terminal, and these are the receptors, and the antibodies are against the receptors. What can happen is activation of this part of the immune system called complement that can cause destruction of the muscle on the opposite side. Where the receptors are located, the antibodies activate this and it causes destruction. And we're going to talk about some of the drugs that are targeting this. The point of this slide is to look at where can we target the immune system along the way. And in this case, you can target upstream or downstream. So complement inhibition is fairly downstream. For instance, cholinesterase inhibitors like Mestinon are downstream. It's right here at where the nerve and the muscle are communicating with one another. We can go back upstream to where the antibodies are, and that's where the drugs we're going to talk kind of extensively about, the FcRn inhibitors. I'll come back to them quite a bit. And then we can target actually the cells maybe that are producing antibodies. I won't talk very much about that today. So it's important to talk about this because as of now, the only FDA approved drugs are those that target, have been studied in people with acetylcholine receptor antibodies. There have been a little bit of study in terms of clinical trials in MuSK antibody positive, and I'll talk briefly about that. And there's other antibodies as well, but they're much less frequent. Those are certainly the two most common. And then there are people who don't have antibodies to any of the things that we test for, and we call that seronegative. And I'll touch on that just a little bit with some of the drugs that we're going to talk about. So the standard treatments, of course, are initially to start a cholinesterase inhibitor, pyridostigmine or Mestinon. Most people will not get a good enough response and they have side effects. And Mestinon has no effect whatsoever on the immune system, and it almost always does not hold people steady. So they need to have something that's going to target the immune system. And although I'm going to talk about the new drugs, I still always use the standard drugs first, prednisone and plus or minus one of these non-steroidal immunosuppressive drugs. And I only move on if patients cannot tolerate these drugs or do not get a good enough response from them. I tend to evaluate that much quicker than some other people in terms of the steroids. And if I can skip the non-steroidal immunosuppressives, if somebody doesn't respond to steroids, I definitely try to do that. Let's say that somebody has not responded to this prednisone, or I've not been able to taper it enough and they're having a lot of side effects in spite of trying these other non-steroidal immunosuppressives like Cellcept or Imuran or methotrexate. Then I will go to the next line. And to me, that's IVIG. Why do I go to IVIG first? Because it doesn't suppress the immune system at all. It's the only one of the treatments that we're going to talk about that has no suppression of the immune system. And so I like to use it next. I will do one single loading dose. And if somebody gets a great response, then I will put them on a maintenance. And whenever we're talking about things from IVIG onward, I'm not looking for a little bit better. I'm looking for a lot better. I want patients to have a no doubt about it improvement. And if they haven't had a no doubt about it improvement, I'm not going to keep them on that treatment. I'm going to try something else. We have had Soliris, the generic name is Eculizumab, approved for several years. And this is actually the first drug that was FDA approved for myasthenia besides Mestinon. Some neurologists and some neuromuscular specialists who've managed a lot of myasthenia patients like Rituximab. I personally don't like it that much for acetylcholine receptor antibody positive, but I think it is the treatment of choice for people who are MuSK antibody positive. I think we should never even bother treating them with steroids or other treatments. We should just go straight to Rituximab. I have 0 patients personally who are on chronic plasma exchange. I think there are other ways to manage people, and every patient gets a complication when they're on chronic plasma exchange. And I'm not going to talk in depth about thymectomy, but that's only a treatment for acetylcholine receptor antibody positive, and probably in people who are younger than 60, and definitely in people younger than 50. So here's the main topic of this talk. What are the treatments on the horizon? Well, 2 of these treatments are now no longer on the horizon. They're actually available. And those are Vyvgart, also known as efgartigimod. And it's in this category of drugs called the FcRn blockers. And I'm going to get into that in a little bit more detail in a second. And then the second class of drugs are the complement inhibitors. And that's the same class of drug that Soliris is. But there are 2 newer drugs. I actually misspelled this. It's ravulizumab, not ravulizumab, but it's called Ultomiris and Zilucoplan. And I'm going to go over all of these drugs with you all, except for Immunovant, because we don't really have much data, and the Nipocalimab, we don't have much data on those yet. So this is the pathway. What does FcRn do? It's a pathway in your body that protects antibodies as they are being transported across a cell. So if the antibody binds to the FcRn protein, it is protected from going into the digestion chamber inside the cell, and it comes back out of the cell on the other side. If you block the FcRn by using an antibody or using a small molecule like efgartigimod, now the antibodies can't bind, they're no longer protected, and they get shuttled into the digestion chamber and destroyed. So for antibody-mediated diseases, this mechanism is almost certain to work. It's almost always going to have an impact on the disease. You're treating the root cause of disease, and myasthenia is what we call the prototypic autoimmune disease. That antibody, we know it causes weakness, and we know if you take it out and you put it into an animal, you can make the animal weak. So in the FcRn pathway, I've kind of mentioned these already. Efgartigimod is one of the drugs. I'm going to talk about Rituximab. It doesn't have a brand name yet. And I'm not going to talk about the other two because we don't have enough data yet on those. But to talk about these, we kind of have to say, what are the outcome measures that we look at in the clinical trials? And two that are used most frequently are called the MGADL, or Activities of Daily Living score, and the QMG, or the Quantitative Myasthenia Gravis score. The other one that I think is pretty important is this thing called the Quality of Life, the MGQOL 15R. I'm going to show these to you real briefly. So I do the ADL and the QOL 15R in the clinic every day whenever I see patients. This only takes a few minutes, and we ask, how have you been doing over the last week or so? So we go across these rows. Do you have any trouble talking? They say, no, we're done. If they say yes, then we say, okay, is it intermittent or is it constant? And if it's constant, then people have trouble understanding you. So we do it that way with every one of these. And this is, how have you been doing in the last week or so? And so the normal score is 0. The maximum score, because there's 8 items, is 24 points. That means you have really terrible disease, the worst possible. The QMG is not something that most people use in the clinic because it's very time consuming. It's really not practical to do it on a daily basis as we're seeing patients in the clinic. We do use it in research trials. People feel it is more objective. It's not just what patients are reporting. If we go back to the Activities of Daily Living score, we have to use what the patient tells us. So sometimes I'll see a patient say, do you have a droopy eyelid? They say no. I look at them and their eyelid's clearly drooping, but we still have to write no if they tell us no. So it's not quite as reliable or as objective as something like the quantitative myasthenia score. And then I mentioned the quality of life score. This one I also do in the clinic, and this one is filled out by the patient. So while they're waiting for me to come into the room, my technician will hand them the clipboard and say, fill this out for us. And it says here, over the past few weeks, how have you been doing? And so do I have this symptom? Not at all, a little bit, or very much. It used to be 5 choices, but they found that limiting it to 3 actually didn't change the sensitivity, etc. So now we're going to go on to talk about the drugs. So efgartigimod, the first drug studied in this FcRn pathway, and it is now FDA approved. It's a smaller molecule. The other candidates in this pathway are all what are called monoclonal antibodies. They tend to, your body tends to react a little bit more to those, so there's a little bit more side effects with those. It is given as an IV infusion once a week. There's 4 doses, and then you wait to see when the symptoms begin to come back, and then you treat as needed. They've actually developed a new formulation that's not intravenous, that's subcutaneous. It's given at the same frequency, and they've shown that that's just as effective, and that's probably going to get approved too. I think I'm going to skip over this and get to some of the outcome measures. And one of the things that people have looked at is this idea of what's called minimal symptom expression. Our goal is to make people as good as they can possibly be when we're treating their myasthenia. And this is a good way of looking at that. So to get that designation, you had to go to a score of a 0 or a 1 on the Activities of Daily Living score. And in this study, 40% of the patients who got treated with the drug had that outcome, and only 11% of the placebo patients. So that's quite a dramatic difference. They did, in their clinical trial, actually study patients with seronegative myasthenia. There was not a statistically significant difference because they only had 19 patients who were seronegative in the trial. But if they combine them together, and looked at both the activities of daily living score and the quantitative myasthenia gravis score, that was significant. The side effects of efgartigimod, headache is a common side effect of all of these drugs. Actually, this particular drug has the lowest incidence of only in the 20s. In this case, it wasn't even different than placebo. But what is a little bit different is the upper respiratory tract infections, and it didn't show up for some reason on this slide, urinary tract infections. So when you lower immunoglobulin levels, it tends to potentially make you a little more likely to develop an infection. There are people out there in the world who have immunodeficiency where their body just doesn't produce enough immunoglobulins, and we have to give them IVIG to prevent them from getting infected. So this is the second one of the drugs that's in this pathway called the FcRn. And now the clinical data is available for this. It has not yet been FDA approved, but this is the data from their clinical trial. It is a treatment that's given IV weekly, and in their clinical trial, they were looking at 6 weeks after the onset of the study. What was the outcome at that time? And they were looking at weekly infusions, and this one is given the evaluation at the 6-week mark. And what they found was that there was a significant drop in this activities of daily living score at day 43 with either of the 2 doses that they looked at, and they were basically about the same difference. And this 2.5 points or 2.6 points difference from the placebo is actually pretty impressive. And I'll show you some other data that might kind of drive that home. They also looked at the quantitative myasthenia gravis score, and similarly, it had a significant impact. This time there was a little bit more benefit with the higher dose than with the lower dose. This is another outcome measure called the composite score, and it also had an impact on that. And then this looks at what effect does it have on the antibodies in the blood. All of these drugs that I'm going to talk about have a similar kind of an impact. Some might have a little bit more lowering of the antibody levels in the blood, and both the total amount of the IgG and the antibodies that we're really interested in, the acetylcholine receptor antibodies, dropped by about 60 to 70%. And all the drugs that I'm talking about in this class have a similar level of impact on those antibodies. If we look at this drug, it had a higher incidence of headache than the previous, I think right here. So headache was in 45% of the patients on the highest dose, 37.7, so about 40% overall, about 20% higher than the placebo group. They say they're mild to moderate, and they can be managed even with over-the-counter medications. There was a higher incidence of infection, just like with efgartigimod, and similar, it's clearly a little bit different than with the placebo. This is an interesting way of sort of displaying the impact of these drugs on, okay, what effect does this have on the improvement? And so you say, what's the percentage of patients who got the drug versus the placebo who had a specific amount of improvement on one of these scales? And I told you, I'm looking for big improvements when I give these medicines. So let's say, how many patients got a 7-point improvement on the myasthenia gravis activities of daily living score? Well, a third of the patients got that big improvement, but only 10% of the placebo. So that difference is about 24%. And if you look at all of these scores, almost every one of them is about 20% different than placebo across the board. It's pretty close, almost all of them. If we look at the similar data for efgartigimod, across the board, the difference is closer to 30%, and in some cases 40% higher with efgartigimod than placebo. And so that's you can't it's not a good idea for us as doctors to sort of make too much of a conclusion about the differences across studies. But this is the only way I know of to sort of have some idea, okay, is this drug more potent or not as potent as another drug? Is to say, what is the placebo subtracted response rates at given levels on these scores? So I think this shows that that efgartigimod is probably a little bit more potent than some of the than Soliris, which is the one I was showing you here. This is the new drug that is out now called Ultomiris. It has been FDA approved. It has basically the same mechanism as Soliris, but Soliris is given every 2 weeks in its maintenance phase. This drug is given every 8 weeks in the maintenance phase. Both of those drugs, and another one I'm going to talk about, any of the drugs that are blocking the complement pathway, you have to have a meningitis vaccination, and you have to get that periodically. In the ravulizumab study, they showed that there was a significant difference between the drug and the placebo in how much change there was in the scores, both the ADL and the QMG score. And this is just showing that when they got to the end of the study, which was at 6 months, the patients who were on the placebo could cross over to the active drug. And you see that right away, they basically caught right up to the patients who had been on the drug all along. And there's basically absolutely no difference in how they're doing compared to the people who've been on the drug all along. The delaying start didn't really make a difference in how they're doing in the long run. And then this is, again, looking at the difference between the drug and placebo. And this looked pretty similar to what we had seen with Soliris, about a 20-point difference, maybe a 15-point difference at some levels. This is for the quantitative myasthenia gravis. I don't think I have one for the ADL score. Actually, here we go. Yeah, so this is the this is minimal manifestations status. This drug had a 25% of patients who were on Ultomiris had that outcome. Remember, this is the one where you had to get down to a 0 or a 1 score. With efgartigimod, that was a 40% versus 10. With Ultomiris, it's a 25% versus a 10. And this is just sort of comparing across multiple different treatments. And the one over here on the right is one I'm going to tell you about in just a second, called Zilucoplan. And it's hard to see it, but the differences there were actually pretty impressive and probably a little bit higher than what had been seen. This is the Soliris data, this is the efgartigimod data, and this is the Zilucoplan data over on the right. That difference is, seems slightly more with the Zilucoplan than it does with eculizumab, the Soliris. And this is just what is the absolute difference in some of these things. This is the activities of daily living score, and it was a 2-point average difference from placebo at the end of 12 weeks. And you can see these drugs actually tend to work pretty quickly. People are already definitely better than the placebo group by the second week. By the first week, even, there's a statistically significant difference. And then this is the other score, the quantitative myasthenia gravis score. And the difference from the placebo group is about 3 points there. And again, that's significant. And so here's a good slide where we're seeing that difference from the placebo of like 24% here, about 19% here. So a little pretty similar to what we saw with Soliris, but maybe just a little bit higher in some of these. And then again, with the quantitative myasthenia gravis score, again, looking at these differences, we're seeing 28% here, 25% here difference from placebo. And I like looking at it this way as a way of saying, okay, how can I compare drug A, B, and C? So there are some unanswered questions still remaining here. So with these FcRn drugs, we don't know what's the consequence of chronically low immunoglobulin levels. Are we going to create an immunodeficiency state? I told you there are people out there who are born with problems in their immune system who have low immunoglobulin levels. We are going to be lowering those levels with the FcRn drugs. Will these drugs work for rescue treatment? Well, interestingly, nobody has done a study yet. I think it would be very brilliant for one of these companies to do this, to say, can we, if somebody's in the hospital, could we use this in place of IVIG or in place of plasma exchange? And I think that's going to be a role for those drugs later on. And the other question is, will other drugs be able to replicate Efgartigimod's success? Well, the other drug, the Rosario, the effectiveness of the drug looked very similar to what was seen with Efgartigimod. One other unanswered question with that drug in particular, Efgartigimod, or Vyvgart, as you guys may know it, in the study, their criteria for retreatment were different than what we're going to be doing in the real world. They were very strict about how they defined retreatment. And because of that, we are going to be using the drug more often. So one of the things that I'm uncertain about still is how often will I need to give it to a patient when I start them on treatment. We're going to give them that first cycle, but when do I need to give them the second cycle? Well, because the retreatment criteria were not what we would do in the real world, it's not going to be the same, and it's almost certainly going to be more frequent than what was done in the clinical trial. So that makes me a little bit uncertain about the safety data in terms of keeping immunoglobulin levels low. What about the complement inhibitor drugs? So the studies that were done with Ultomiris, the newly approved drug, and with the Zilucoplan, the other drug that's I mentioned, those are both also complement inhibitors. They looked at less affected patients, and that might have affected the impact. What is going to happen with Soliris? Are they going to just get rid of it? Is it going to be totally replaced by Ultomiris? I think it probably will be, actually. There's some other drugs that are being developed in this complement pathway. I think once we have 3 drugs, I don't know that there's any actual need to have other drugs in the complement pathway, personally. So why should I pick one of these drugs against the other ones? What reason would I choose A versus B versus C? Well, you know, it depends on what it is that's important to the patient. Is it, I want the drug that's going to be the most potent one? Is that going to be the reason I pick it? Or is it going to be, well, I want something that's more convenient. It isn't such a treatment burden. So how often do I need to get this drug? Where do I have to get it? Do I have to go to some infusion center to get it done? Or can I get it at my home? Do I have to have these meningitis vaccinations? How much of a burden is that on me? Etc. And then there's the safety issue. There's always a risk of suppressing the immune system. Our experience with using things like Prednisone and Cellcept and Imuran has told us that these things probably aren't as big of an issue as we thought they might be, because we almost never see people having severe infectious complications from these drugs. You notice I say almost never. Of course, you can never say never. Once in a while, it does happen. So this is still something that nobody is going to be able to give you a hard and fast answer and say, you should go from A to B to C. If you fail A, go to B, go to C. I still think we should use IVIG first. I'm looking for big effects of these drugs. These drugs are very expensive. I'm not going to be satisfied giving somebody a very expensive drug and seeing only a little improvement in their disease activity. I could probably get them better like that, even without using one of these expensive drugs, just tweaking their other medicines. So I'm looking for a big bang for my buck when I'm going to the later line treatments. And I think we're right at the pretty much at the 30-minute mark. So I'm going to stop there, and then I'm going to open it up to the questions.
Right, thank you for your presentation. That was a wonderful presentation, and we do have lots of questions in the chat. So the first question is if you're diagnosed with mild MG, is a disease progress determined by hemostasis from the point of diagnosis or remain mild?
So everyone's different. So there are some people whose disease never becomes severe. There are some people who the very first time they are diagnosed, they're doing terrible. They show up and they're having trouble breathing, swallowing, etc. When I see somebody who's doing terrible at the beginning, I put them in the hospital immediately and I do a rescue treatment for them and I start them on high dose steroids all at the same time, all at once. If they've never had any kind of treatment before and they're really doing terrible, I always choose plasma exchange in that situation because I think it's much more reliable. IVIG usually works, plasma exchange always works. So that's my philosophy. And I say if I'm on the ventilator because of myasthenia, I don't want to probably get off the ventilator. I want to definitely get off the ventilator. So that's why I do plasma exchange. The exception is somebody has a history of being treated with IVIG and they had an excellent response, then okay, I'll treat them the next time with IVIG. That's fine. If you have mild disease, it certainly can progress and it can become more severe. Our job is to try to prevent that from happening with the treatments that we're going to give you.
Okay. Next question is, are there plans to expand VYVGART study to include more seronegative patients so this can get FDA approved for seronegative patients?
So the short answer is I don't believe so. I think they're probably going to use what they call real world data. They're going to rely on people like me and other myasthenia experts saying, well, we do have some data and here's the data that we have from the study. And if we look at the combination of these two outcome measures, we can see there is a difference in the seronegative patients. And so we're going to try to petition them and say, look, we want to try it in this patient. And if they say, no, you can't do it, then we appeal it and say, look, they've tried A and B and C. And they failed all of the above. And so we really want to try it in this patient. And, we just have to keep advocating and presenting what the evidence that we do have. I don't work for the company, so I can't say for sure what their plans are, but I don't think that's likely.
When you say a drug is not approved for MG, how is it that some patients are taking it? Is insurance not covering it?
So that's totally variable, right? So it depends a lot of course, the big factor is cost. So Prednisone is not approved for myasthenia, but nobody cares because it's super cheap. And even like azathioprine or methotrexate or drugs like that, they're not approved, but for the most part, people don't care because they're not very expensive. There was a time where Cellcept, we had hard times getting that. We had to appeal and things like that. We almost never have to do that anymore. But when it gets to the very expensive drugs, yeah, they're going to be very unlikely to say, sure, you can use this drug in a patient that doesn't fit the criteria. They're going to fight you tooth and nail in that situation. The exceptions of a drug that's relatively expensive, I would say, is the Rituximab for MuSK-MG, where we've been pretty successful because I think there's pretty compelling data that it's actually in the best interest of the insurance companies to let people have it, because otherwise the patient's going in the hospital repeatedly and having to get plasma exchange and things like that. And they get Rituximab and it like knocks their disease out, and now they don't have to go to the hospital. So it actually saves the insurance company a lot of money in the long run.
Why is it MG patients react so differently to the medications?
That's a good question. I think there are some treatments that work universally, like plasma exchange. I've never personally seen a patient get plasma exchange and not get better. Never seen it happen. If they have autoimmune myasthenia, if they don't respond to plasma exchange, it makes me think they don't have autoimmune myasthenia. I'm pretty convinced of that. But I don't know is the short answer. And I guess that's why they call it the snowflake disease, that everybody's different and how their disease behaves. There are certain things about MG that tend to be pretty consistent, and that is in a given patient, the pattern of disease tends to repeat itself. So if the first symptom was a droopy eyelid, and now, and you went on to have other symptoms, you had slurred speech and you had shortness of breath, and you've gotten better, the first symptom that you're getting weak again is usually the first one that you had in the beginning. Not 100%. You can't say, it's always going to be true, but in most people that it follows the same pattern in that individual person, but everybody tends to be kind of different. So some people it's slurred speech, some people it's weakness in their arm or leg, and most people it's eyes as the very first symptom.
Why are seronegative patients not included in clinical trials?
Mainly because they are poorly defined. How do you decide that somebody has myasthenia gravis who doesn't have antibodies? So they have symptoms that fit. So they have weakness that fluctuates and fatigue. So it has the classic pattern. Rest makes them better. Activity makes them worse. It recovers with a little bit of rest. In my opinion, there has to be some responsiveness to a treatment targeted to the immune system. If somebody comes in and says, I have seronegative myasthenia and I got plasma exchange and I didn't get better, I don't believe they have myasthenia gravis. They don't have autoimmune myasthenia gravis. That's my bias. I like to say if everything about your disease is atypical, you probably don't have that disease. So if somebody comes in and they say, they tested me for antibodies and I don't have any of the antibodies. Okay, well, that's not typical, but it definitely happens. Okay, I tried Mestinon, it didn't help me. Well, that's not typical, but it can happen. Okay, I tried steroids, they didn't help me at all. And that's not typical, but it could happen. I got plasma exchange and it didn't make me better. Well, that's not very typical at all. And as I said, to me, that's kind of the deal breaker. And then there's electrical studies. I had a repetitive stimulation test where I had a single fiber EMG, and those were negative. Well, if everything's on the atypical side of that equation, you probably don't have the disease. And that's true for any disease. If like everything about your quote disease is not typical, then you probably don't have it.
So what about the ones that are typical myasthenia that are seronegative? Is there any research or future research that's going to be looked at to see if patients do eventually convert?
So it's interesting there's a different test for antibodies than the one that's usually available in the United States called a cell-based assay. There's a lab in Oxford, England that's been doing this for like at least 10 years now, not longer than that. And now there's a lab in Canada that is doing it commercially. Theirs is a little bit different, I understand, than the Oxford test, but so it's testing mainly for acetylcholine receptor antibodies. And I personally sent 8 patients who were seronegative and 3 came back positive in that test, which can be really, really important, especially because these are now acetylcholine receptor antibody positive patients. They were previously seronegative and now they're acetylcholine receptor antibody positive. So now they can get all of these treatments that are only approved for acetylcholine receptor antibody positive. So that is a testing that is evolving, and hopefully it'll be more widely available at some point in the near future, so we can help out more of the previously seronegative patients.
A follow-up question, does insurance cover that test?
No, they don't. As far as I know, at least the one in Oxford, England, they don't. I'm not sure about the one in Canada. So the patients that they actually, believe it or not, the biggest cost was shipping their blood across the pond. It was extremely expensive. So that's one of the reasons I waited until I had 8 patients so they could split the cost of it. They had to pay for it out of pocket. It ended up costing them like about $200 a patient out of pocket, or so, somewhere in that range, to get the test done.
What are the primary sources of your research? Are these studies a combination of trials provided, or are they partially paid by pharmaceutical companies and independently analyzed?
So drug studies that are for new products are, of course, going to be sponsored by the pharmaceutical company, and they're going to be analyzed by the pharmaceutical company. Of course, we as the clinicians, we're the ones who recruit the patients into the clinical trials. We're going to be sort of advising them on, you know, how should, when we go to meet, when they're doing these preliminary meetings for the studies, and they're talking about how they're going to design it, we're giving them feedback and things of that nature. No, we don't think this is a good idea, or this is a great idea, or whatever. And in terms of analysis, a lot of that is left up to kind of statisticians, and how do you decide, is this significant? One of the things I'll say, there was too much focus, I think, in the Efgartigimod, the Vyvgart study, on 2-point improvement in the ADL score being a clinically meaningful difference. When I'm using late line treatments, 2 points is not enough for me on the ADL score. So I didn't like that they focused on that so much, and that was one of the reasons I didn't like the way that they chose their retreatment criteria in the study.
Just a couple follow-up questions about the cell-based analysis. How can the provider order it? And is there any drug companies that are paying for that test?
Well, somebody wrote it here, there is a drug company that is paying. I don't know that. I'm not aware that there is a drug company paying for the test personally, but there is. I'd like to hear about that personally, but anybody can order the test from the folks in Oxford, England. You can go online, and any doctor can do that. It's a lot of work, honestly, to get it done. Takes quite a bit of legwork on the part of the physician or their, people who work with them. So you're saying Alexion pays for it? I'm not aware of that, honestly. I didn't know that was true. Okay.
All of these meds are pretty much contraindicated for MG patients who have CVID already.
Who have, I'm sorry? Patients who have, I didn't get that part.
I think she froze,
All of
Dr.
these,
Pulley.
all patients, can you hear me?
Yeah, I hear you.
Are all of these medications pretty much contraindicated for MG patients who have CVID already?
So I would have to defer that to an immunologist for them to say, but I would say a complement inhibitor probably is not. I would say the FcRn drugs probably are, but I don't know the exact definitions of the CVID. I know there are the patients who have low immunoglobulin levels. Okay, I don't know all the categorizations and designations of that, but I can tell you, if your disease causes you to have low immunoglobulin levels, then yes, probably FcRn drugs should not be used in those patients.
All right, now our last question will be, will insurance company authorize emergency use?
So I think that's on a case-by-case basis. And even sometimes it's a hospital decision, believe it or not. So we have patients who are in the hospital who we just can't get them better, no matter what we're doing. We've done plasma exchange, we've done IVIG, we've put them on high-dose steroids, and everything is failing. And this patient is stuck in the hospital, can't get them off a ventilator, they're on a feeding tube. There have been cases where the hospital, in spite of the big cost to them, said it's cheaper for us if we can get this patient better and get them out of the hospital, to give them this really expensive drug, and see if we can, pull them out of this situation, because patients who are in that scenario, they actually, the hospital loses a lot of money on those kinds of patients. So they sort of have to take a gamble in some instances and say, it's going to cost us a lot of money to do this, but it may save us money instead of this patient just sitting here in the hospital and never getting better.
Well, thank you very much, Dr. Pulley. It was a wonderful topic and lots of discussion.
Thank you very much.
Okay, our next speaker is Melissa Woolhurst. Melissa's career and volunteer efforts carry a recurring theme of finding proactive solutions to address challenging situations. From her leadership in revitalizing blighted communities, mediation, and community consensus building as the executive director of West Palm Beach Downtown Development Authority, to her volunteerism as a crisis counselor, homeless assistance advocate, and as an MG friend, peer-to-peer support volunteer, Melissa strives to find solutions that better communities and individuals. She is an advocate for myasthenia gravis awareness and assistance as moderator and administrator for several online support groups, including Seronegative myasthenia gravis. With the help of her supportive family and friends, plus an expert medical team, Melissa doesn't let her over 35 years with myasthenia gravis stop her from embracing her life and being of service. Melissa, we're going to turn it over to you.
Thank you so much. Thank you, Kathy, and thank you to the MGFA for giving me the opportunity to speak today and for presenting these wonderful speakers. It's been so helpful, and there's been such valuable information from Dr. Pulley, Dr. Plowman, and Dr. Rosario. Before I really dig in, I'm going to try to toggle my screen here and share a PSA from some seronegative patients. So if you bear with me, I'm going to try to share my screen and open something up here. Let's see. I'm not as nimble as everybody else seems to be with this. So
I have seronegative myasthenia gravis. Seronegative myasthenia gravis. I have seronegative myasthenia gravis. I have seronegative myasthenia gravis. Myasthenia gravis is characterized by fluctuating weakness of the voluntary muscle groups.
The muscle weakness of MG increases with continued or repetitive activity
and improves after periods of rest.
Seronegative myasthenia gravis is a form of MG where antibodies like anti-AChR and anti-MuSK are not detectable in our blood.
Approximately 10% of all individuals with MG are seronegative.
Individuals with seronegative myasthenia gravis are fighting the same war as individuals with detectable antibodies.
Without the same arsenal of treatments available to us.
Symptoms and response to treatments are often the same in seronegative MG as those with positive antibodies.
Symptoms of myasthenia gravis can include
Drooping of one or both eyelids,
Double vision. Weakness in arms, hands, fingers, neck,
face or legs, or difficulty walking.
Difficulty in chewing, swallowing, or talking.
Shortness of breath, difficulty taking a deep breath, or coughing.
mask-like or expressionless face,
Or difficulty smiling.
and generalized weakness.
Sometimes antibodies for other proteins such as agrin or LRP4 autoantibodies are present.
More research is needed to further understand these antibodies and to find additional antibodies that have not yet been identified in seronegative individuals.
In a recent study, 18.2% of seronegative myasthenia patients actually tested positive for AChR antibodies using cell-based assay testing. Published in the Journal of Neuroimmunology is the clinical need for clustered AChR cell-based assay testing of seronegative MG.
Unfortunately, this test is not available in the US
or most countries in the world.
I have
seronegative.
seronegative.
Seronegative MG.
I have seronegative MG.
I have seronegative MG.
I have seronegative.
MG.
Seronegative.
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 I have seronegative MG.
Sometimes I'm down, sometimes I'm
Thank you so much for allowing me to share that very important message today from the MG community. I am just going to switch over. Okay, I'll switch over to the presentation, and thank you to Celia Meyer, Bob Ruff, and Alicia Angel for putting together that content. And many thanks to all in the MG community, our seronegative patients that participated in that and continually participate in awareness and advocacy efforts. I bet, as you know by now, I have seronegative MG. My name is Melissa Wollist, and today I'm going to be sharing my diagnostic journey with you.
So we're still seeing the screen with the movie, with the video.
Oh, I'm so sorry. Okay, let's see. I'm seeing the other one. So let's see. Maybe if I
If you go back to the Zoom and stop sharing,
okay,
then you'll reshare the other screen.
Okay. Thanks so much, Dova.
Sure.
One
No
second.
problem.
And for some reason, okay. Let's see. Stop share. And let's see. And now we'll try this.
Now try to share screen.
Okay, how's that working?
Nope.
Nope. Okay. One more.
Bottom of the Zoom, you'll see the share screen. When you scroll over it, it'll turn green.
Okay, let me just go back to Zoom. Thank you guys for your patience. Share screen and
There we go.
Okay, great. Thank you guys so much. And here we go. Okay, so as you know, I have seronegative myasthenia gravis, and I think Dr. Rosario and Dr. Pulley, the other speakers, really covered what seronegative MG is very, very well. Although antibodies are not able to be seen in the blood work, it doesn't mean that there are not other biomarkers or antibodies that have yet to be discovered or identified in this type of myasthenia gravis. So I'm here today really to share my diagnostic journey with you guys. Because I have seronegative MG and because my symptoms started when I was a teen and were kind of mild and followed by other illnesses, it took 16 years from the start of my symptoms to the actual diagnosis. I've been officially diagnosed for 22 years, which means I have been battling, surviving, and thriving with MG for 38 years, which is 70% of my life. So I've actually lived more of my years with MG than I have not. But today I want to focus on those first 16 years so you can get an idea of how symptoms might manifest, particularly in kids, teens, and young adults. I think there's so many bodily changes that go on during that time. There's changing life responsibilities. So it's really easy for some of those symptoms to kind of be shrugged off, fall through the cracks, or maybe even be misdiagnosed at that stage. Especially if you're seronegative. Of course, much more is known now than 38 years ago when I first started showing symptoms, but we still see patients that are experiencing these long lags in diagnosis And unfortunately, in the seronegative community, we're also seeing patients that are diagnosed, they start to do better, maybe switch doctors, maybe not, then they're, suddenly cured, they get undiagnosed. And then they start failing again and they get re-diagnosed again. So awareness and advocacy is really key, especially when dealing with seronegative MG. So the first 5 years when my symptoms showed up, I see a little ptosis in this picture, but it wasn't anything that was noticeable. I did have mainly voice changes. That was really the most tangible symptom that I had. My voice became very, very raspy. I'd have this all the time. And it would go away if I would rest for, a day or not speak for a day. My voice would be fine. And then if I spoke a lot, it would start getting raspy and I'd have volume control issues, which, now I know to be, it's a pretty classic MG symptoms. I started getting really clumsy, and I know you guys with MG can understand when you're walking down a hall and you're kind of bouncing off the walls to get somewhere, or dropping things because your hands just aren't able to hold things up. I started getting this feeling that I would not have classified as weakness. It just felt like it felt like I was carrying around, another person or an extra 300 pounds on me. It became very difficult to move at times. I could not exercise at all. And I'd be down and out for a couple of hours after. I started missing classes in college, really because I couldn't walk around the campus. It was really, really difficult for me. And I lived on the 4th floor of my dorm, and to get up those stairs, because they didn't have elevators then, it was near impossible. I didn't tell anybody what was going on because I was really embarrassed. I didn't know if I was lazy or just inactive. I just didn't understand that this could possibly be a neuromuscular disease. The other thing that I still do to this day, if I was out with friends at a party, at an event, I would find a quiet corner, or I'd even go out to my car sometimes, and I still do this, and I would lay down and rest. And after about an hour, I'd be ready to go again. But I found that when I would rest, I could get up and do things again. So that continued. That was kind of my life for 5 years. I figured out my own ways to accommodate for these mysterious symptoms that were based in this neuromuscular disease. After those 5 years as a young adult, I had a bout of mono and bronchitis. I was given a whole bunch of antibiotics that probably weren't good for MG. And I started experiencing what was likely an extreme exacerbation of the MG symptoms. I had breathing issues, very labored breathing. I couldn't lay flat. I was diagnosed with asthma. I guess I do have asthma, but these symptoms went far beyond asthma. That heavy body feeling turned into a complete inability to walk. Sometimes I had to be guided to the bathroom or carried to the bathroom. I was unable to chew. I'd start eating something and my mouth wouldn't work, which resulted in excessive weight loss. And unfortunately, doctors saying that I must be anorexic because I wasn't eating and I was losing weight. These are the types of significant symptoms that can just fall through the cracks due to age a lot of times, I think. And what I found was that cold weather, extreme cold, made everything so much worse. I could not breathe outside at all. I had a very difficult time walking. The weight of clothing was just too much, of coats. My parents would pick me up at my apartment and drive me to the front door. of my office because I couldn't make it from the parking lot to the front door, which was ridiculous that I tried to continue working. But eventually I could not work anymore. I saw countless doctors, mostly infectious disease specialists, because I had the mono and bronchitis thing. So I don't know if I was misdiagnosed or underdiagnosed with chronic fatigue syndrome, Epstein-Barr virus, chronic Lyme disease. I went to Mass General. I lived in New England at the time and saw an amazing infectious disease doctor there. And she did just about every test she could possibly do and came to me and said the most compassionate thing she could say. She said, I really feel like you have an autoimmune disease, but I can't identify it. I've run all of these tests. I can't identify it. And it can take 5 to 10 years for an autoimmune disease to manifest in such a way that it is identifiable. I was frustrated. She was frustrated, but I felt seen. And I figured, gosh, I just have to kind of wait this out. But what am I going to do in the meantime until it shows up? So I became a little bit doctor wary. I felt like I had seen so many doctors. So I kind of started out on a new path while I was waiting for this disease to kind of show up. I continued my rest and repair cycle. I saw a therapist that specialized in chronic illness, which was incredibly helpful and supportive. I saw an acupuncturist that helped me make diet and lifestyle changes. And this was 30 years ago. So it was way before there was autoimmune paleo diets and Tai Chi and meditation. You know, those have really become part of our complement care now. But this was before all that. And I have to say it definitely helped, the changing lifestyle and dietary changes and acupuncture. This acupuncturist also over time noticed that whenever I had my menstrual cycle, whatever these symptoms were, they would get much worse. So he worked to kind of stabilize my hormones. And things started slowly getting better, but every time winter would hit, it was just a mess again. I just could not take the extreme cold. So I did the only thing I knew to do. I was feeling a little bit better and packed up from New England and moved to Florida. Of course, I didn't know about extreme heat and MG because I didn't know I had MG. But I moved down to Florida. I felt great. I started working again, and all was well until my symptoms appeared in a new way. I was diagnosed with Graves' disease, which involves an overactive thyroid and can happen. There's a little higher incidence of thyroid disease in people that have myasthenia gravis. So, you know, we added that to the mix just to confuse doctors a little bit more. And because thyroid imbalances can impact MG, I began having swallowing issues, which I had never had before. And I assumed, because if I'm eating and I can't swallow, I must be having an allergic reaction to something. So I would go to the ER, tell the ER doctors that I must be having an allergic reaction. They would do IV steroids, send me away with steroids, and I would feel a little bit better, but not completely better. I was kind of leading doctors down the wrong path, and instead of saying, you know, I can't swallow, I don't know what's going on. But the only frame of reference that I had was that, well, I can't swallow, I must be having an allergic reaction. Except my doctors couldn't find any allergies. So they were kind of perplexed. My neck, I started having really bad neck weakness, and it was harder to hold up my head. My arms and my hands were involved. I definitely started having a lot of anxiety around that time, and my breathing problems increased. And at this point, no amount of natural remedies or alternative medicine was working. Rest was helping a little bit. Prednisone was helping a little bit. And I was able to start working from home. So doing rest and prednisone and working from home, I kind of was able to get to a decent level of functionality. And the swallowing issues kind of resolved. But I had doctors that were like, you know, something's not adding up here. You have chronic fatigue syndrome, but you can't walk sometimes and you can't swallow. And one of my doctors said, you know what, I think you might have this thing called myasthenia gravis. So I'm going to send you to a neurologist. And I was like, gosh, what is this? You know, and I went to a neurologist, and I was 92 pounds, and at 5'5", I was really, really skinny. And that neuro basically berated me for being there because I was wasting his time, because myasthenia gravis is only an older person's disease, and there was absolutely no way I could have it. I was too fit. You know, I was 92 pounds and he felt that that looked too fit. And I was too young, and there was just no way that I had MG, but he'd run the blood work anyway. And of course, because I'm seronegative, my blood work was negative. So my general doctor was really shocked. He felt he had solved the puzzle. All the signs for him were there, but for the neurologist that I saw, they weren't. So I was just missing this one symptom. And remember this, this infectious disease doctor that I saw 11 years ago said that this autoimmune disease had to manifest in a certain way so that it was identifiable. And very late to the party, 16 years later, mitosis shows up. And it was blatant. You know, every doctor could see it. I didn't know what was going on. And I went to my general doctor, and this time he said, okay, I need to send you to a doctor that is very familiar with MG. And from there, everything happened quickly. It was crazy. I went 16 years struggling, and from that moment, when one eyelid was, you know, practically shutting at night and the other was open, it was pretty quick to get a diagnosis. The neurologist that saw me diagnosed me preliminarily in about an hour. He followed up with some blood work for MG, but he did not feel that I would show up positive for the antibodies. Thankfully, 22 years ago, he was seronegative aware, and he knew that antibody level didn't mean anything for him if I had all the symptoms. And he gave me instructions for a Mestinon trial. After a week on Mestinon, everything started feeling better. My eyes started resolving. My body heaviness started going away. It was like a light bulb was turned on for me. That neurologist did a repetitive nerve study, but I was at that point, I was on pretty high doses of Mestinon, and he had me on it while I was doing the study. So it was kind of inconclusive and borderline. So he sent me to a neuromuscular specialist in Miami, Dr. Bradley, who he considered to be an MG expert. He had been working for years and years with MG patients. So Dr. Bradley's office told me, you know, don't take any Mestinon before you come in. He examined me very thoroughly, heard my history, had me take I think 2 Mestinon, sent me out into the office for an hour or two, and then brought me back in and examined me again. He confirmed after 16 years, he confirmed my diagnosis of seronegative MG. He didn't want to put me through an additional repetitive nerve study or a single fiber EMG, because he felt that the exam and that trial of Mestinon made it very, very clear. So I was diagnosed 22 years ago, and in those 22 years since diagnosis, I've lived a lot of life, and a lot of it I never dreamed. When I was very ill when I was a young adult, I never dreamed of the things that I would be able to do. I established a successful career, got married, we bought cars, we bought homes, we weren't living lavishly. We were just, able to, I thought I would be living with my parents for the rest of my life. And here I was living independently and able to have a life. Most surprising of all, I became pregnant at 40. I never thought that I would, be able to have a child and raise a child with my physical state. And I now have a 15-year-old daughter. But life is not without its challenges. And I'm just going to spend a little time on this because I wanted to focus on the diagnosis part. But because I was feeling better than ever, I kind of thought I was invincible. And I really worked myself to the bone. And I was a parent now, so I was kind of burning the candles at both ends. I was working really hard and I was trying to parent at the same time. And my MG really went haywire. It was the worst. It was the worst it had ever been. I ended up hospitalized 12 times in 18 months. And as you can tell in the photo on the right, I had a very long-term relationship with high doses of steroids at that point because they worked. They were the things that worked for me, although they were really hard on my body. They kept me alive. My doctor in Miami had since retired, and I was referred to an incredible seronegative friendly neurologist in St. Petersburg, Florida, that I think a lot of you know, and he works with Dr. Rosario. I started seeing Dr. Weiss. Dr. Weiss suggested that I have a thymectomy and start on immunosuppressants. Now, I'd had scans in the past that didn't really show any thymus issues. So I had been kind of resistant to even consider a thymectomy, but at this point I had nothing to lose. I had a 2-year-old at home and I felt like I was losing the battle of my life. And I'm still very emotional talking about it because it was a really hard time. So I did have the thymectomy. After the surgery, pathology showed that I had several encapsulated thymomas in the tissue that was removed. And the surgeon stated that I had hyperplasia, which is an overgrowth of the thymus tissue. And it was scattered from my jawline to my last rib. So he had to take out quite a bit of tissue. And he said it looked like my thymus had exploded in my chest. That was the only way he could describe it. So I am forever grateful to the expertise of Dr. Weiss, which really allowed me to live and thrive in these past 12 years post-surgery, and I'm planning on a lot more years ahead too. So my story is quite long. My diagnostic journey is long, and I talk about my diagnostic journey and my experiences in hopes that others don't have to struggle for 16 years for a diagnosis. And from what I'm seeing and hearing a lot in the community now, there is hope for a lot of us, specifically seronegative MG. There's a lot of research and there are clinical trials in MG right now. And I think I heard Dr. Pulley and Dr. Rosario say that there's one clinical trial that is including seronegative patients. So that's encouraging, but we all want to advocate for more of those. And there is a seronegative MG focused project, research project that was initiated by the MGFA with a generous donation from Susan Johnson, who is a fellow seronegative MG patient. So we're so very grateful to her for her contributions and to the MGFA. And MGNet, that is a has been established by the National Institute of Health as a rare disease network for MG. They're working with academic medical centers, the MGFA and Conquer MG, to research biomarkers specifically for seronegative MG. So we've got people doing the work. So hopefully, you know, we can have some sort of testing that can diagnose someone with all of the symptoms, but not the antibodies. Hopefully they can get diagnosed much sooner. So if you are struggling with care or diagnosis, do not delay in getting expert care. I travel 9 hours round trip to my neurologist. And when I couldn't dress myself and I couldn't brush my teeth without going into crisis, that was a really scary trip to take with my family. It's a hardship to travel, but it is 100% worthwhile, especially if you're seronegative and especially if you're having a really hard time with your MG, if it's significant. Getting to an expert that understands this disease is very, very important because you want to have proactive care to keep you out of the hospital. You can go to the MGFA website for their Partners in Care information. They have information on neuromuscular doctors. And then I also like to go into the support groups on Facebook and regular support groups and kind of ask around, because we're all patients. We have the experiences directly with some of these doctors. So that can be very helpful to just, you know, kind of cross-reference. Also, make sure that you get educated on your disease if you are not already. And most of you that are here for that reason. So you're already ahead of the game. But make sure that you know what medications that if you take them, they may flare your MG. That is very important information to know. Know your triggers for you personally, because they might not be the same. It is the snowflake disease. It could be stress, extreme temperatures, illness. It can be having your period. It can be dehydration, low potassium levels, whatever it is, you know, see if you can kind of get in tune with your body and figure out where your, you know, kryptonite is, for lack of a better word. And make sure your family knows and understands, and your friends and your loved ones. Give them information, have them join you at a doctor's appointment, have them join in on some of these seminars. Make sure that they're supporting you in every way. Try not to self-diagnose. As I did in some cases with going into the emergency room saying, I can't swallow, I have an allergy, or I can't breathe, it must be my asthma. You know, give doctors a little leeway. That was some advice one of my doctors gave me, you know, tell me your symptoms so that way I can figure out what it is instead of you leading me in a certain direction. Also, don't accept every issue as being MG. You may be having breathing problems, but that needs to be evaluated by a doctor because it could be your MG, it could be something else. And anytime you're having breathing problems, you should be evaluated by your doctor anyway. But it could be something other than MG. If you're having a swallowing issue, it could be something other than MG. So you just want to make sure that you're not kind of brushing aside too many things saying, oh, it must be because I have MG. If you have new symptoms that are showing up, that they're new to you, I personally call my neurologist. Anytime I've had a new symptom that just kind of pops up, or a symptom I haven't had in a while that's showing up again, I'll call my neurologist and see, do I need to have some blood work done? Do I need to change something I'm doing or change my medication? Be a partner in your own care. And get emotional support. This is a long journey. There are support groups on Zoom, as you guys know, because you're here. There is an MG Friends program through the MGFA where you can be connected with another patient that has MG, and they can kind of walk in partnership with you and help you through some rough patches. That's also available to caregivers, which is very important. I have found therapy to be extremely helpful. So I will dip in and out of therapy, of mental health therapy, health therapy. This is long-term stuff. When I was first diagnosed, I had never met anybody with MG. And I did feel very alone. Now with the internet and strong patient advocacy groups, we don't have to walk this path alone anymore. So reach out, build your community. It makes all the difference. And finally, never give up. If you are not diagnosed and you're struggling, I see you and others see you because we understand we've walked this walk. So hang in there, don't give up. There is help available. You don't need to be on this journey alone. I wish you guys all the best on your personal journeys. And I thank you so much for your time today. And if anyone has any questions.
Alyssa, that was a great presentation. And I do have some questions.
Okay.
I just want to caveat by saying I have my grandson here. So excuse me if you hear some water running in the back. He's taking this opportunity of playing the sink while I can't talk, right? What has been the most frustrating part of having seronegative MG, if you could define one part?
I think it was going through the diagnostic process, especially being young and going through the diagnostic process and almost being treated as though I was crazy and that there was something mentally wrong with me. And, I looked fit, having people say things like that. No, you can't be sick. Look at you. You look great. There's no way there can be anything wrong with you. Being dismissed. It was really mentally grueling. And I think that was the hardest part, feeling unheard and not believed.
I'm sure a lot of us can relate to that. So this is a great segue to the next one. So what do you tell others, your loved ones, your family, friends, medical professionals who may not believe in your diagnosis because you don't have that blood test that shows that you have MG?
Yeah, it's really challenging because people that were really close to me, things got pretty severe for me a few times. So people that were really close to me saw it and they understood and it became evident. And the other people, I've made friends and I've lost friends, and I've made the best friends in my life since my diagnosis with people that support me. I stopped trying to convince anybody that, I can only do things, during this time of day because I need to rest. And, if they don't understand and don't care to understand, it's not my fight to make them understand. And that's a really hard truth. When I went through one of my really bad episodes, I was engaged, and the person that I was with was not supportive, and it was, so devastating to me. I was young and in love, and I had to let that relationship go. But you know what? It was the best thing for me because I moved on to people that truly are supportive.
I loved that quote. It's not my fight. Loved that. Thanks, Melissa. So, and on that same realm, so you have said that you live quite a distance away from your seronegative friendly physician. How do you advocate for yourself if you need medical treatment closer to home?
That I will be honest with you, that was a tough journey, and I'm really glad you asked that question, because when I had a local neurologist at one point that didn't go to the hospital. And before I started seeing my neurologist, 9 hours round trip away. And so I'd get to the hospital and really nobody wanted to put their hands on me or touch me. And it was really hard. I'd go in, I couldn't breathe, and would hear sometimes, no, you're just having a panic attack. And I'm like, well, yeah, because I can't breathe. So kind of you get into a panic when you can't breathe. So I was very fortunate that my lung doctor and I have a cardiologist, and they got to talking when I was in the hospital one time, and they said, you know what, you need doctors that come to the hospital. And they worked to set me up with a general practitioner that goes to my local hospital, a neurologist that goes to my local hospital that will defer to my neurologist far away. If necessary, he'll confer with him, and I only see him once a year. So they set up a local network for me to make sure that when I went to my local hospital, I had doctors there that knew me, knew my case, knew my history, and could be called to bring in help. Because I was in the hospital once and I kept giving them Dr. Weiss's phone number, and nobody would call Dr. Weiss. And it was something that, like, my potassium was low and I just needed some hydration and potassium, and he knew that, but they would not call him. So, so you really need to have a good home base in case you need it. My doctor feels like part of his job is to keep me out of the hospital. So that's what we try to do. And we try to be very proactive, and I stay in communication with him if I have any issues. So hopefully we can bypass that. And it's been working for a while.
I think you're right. Communication is such a big part of this journey. So how do you describe MG to other people? Like, again, especially seronegative, I think is another level. When there's commercials for Vyvgart on TV and all that. How do you describe MG?
Yeah. So I try to keep it simple. So I just say that there's a problem between my nerves and muscles, and there's a chemical between the two, and it just doesn't work sometimes. And we don't know why. So things that my nervous system and my brain should be telling my muscles to do, it just doesn't happen at times. And then I use examples of what it can impact. So sometimes I can have trouble walking, or I can have trouble, opening things or lifting things up. Or you might hear my voice gets hoarse, or it gets nasally. Sometimes I can't breathe. Sometimes I can't swallow. So it's anything that's involved with your muscles. There's a blockage between the connection. So that's typically how I explain it.
It's a great explanation. Melissa, I saw in the news article they called you the downtown dynamo, but I definitely think you're our myasthenic dynamo.
Oh, thank you, Kathy.
Appreciate all you've done for the community.
So
And it was a great presentation. And,
thank you.
I think a lot of seronegative patients can relate, and patients who are not seronegative have an understanding of that journey. Although we know for everybody, MG can be a very difficult journey to diagnosis.
Absolutely. Absolutely. Yes. Thank you so much for the time today.
Oh, thank you for sharing our Saturday. All right. So we are going to talk about something new that is happening this year. Sorry, I have to have notes. The community health fairs are new to the MGFA, and they will bring the MG community together in a different way than we've experienced before. This year, there are 5 venues. Alexandria, Virginia, which will be held on October 1st, Atlanta, Georgia, November 6th, Austin, Texas area, September 10th, San Francisco, August 14th, and then hopefully Tampa Bay on November 12th. We're still seeking a venue for that one. So what this is to connect people, share, and to learn. So hopefully patients, caregivers, healthcare community, general community at large will be able to interact with the other MG patients and medical experts in the field of myasthenia gravis. There are also going to be educational material available. There'll be local businesses at each one who support the MG community, things like medical devices, some of the healthcare providers, things, medical alert companies, anything that might support the MG community, because this is all about the MG community. And there'll be the MG experience. So, we talked to Melissa, like, how do you explain MG? Well, the MG experience is one way that'll help you to help somebody understand about MG. This is a great event to bring a caregiver to, or somebody who's maybe not understanding what you're going through, so that they can experience somewhat what MG is like. There is registration on myasthenia.org, and Dova has brought that up to show us. It's under the event tab. And these will be expanding as the need is there over the next year, we're hoping. So I'm hoping this will be a great event for the MG community to get together, for people who don't know about MG to learn about MG. If you have any suggestions to somebody that you would like to see at the health fair, please reach out. There is a vendor form for any vendors. There's also a volunteer form, and there's a register form under each tab. Again, Florida doesn't have the date. Sorry, that's all on me. Still trying to find a venue. But I think these are really exciting. I wish I could travel to go see one of them besides our own. And then the other thing we wanted to talk about was the support groups. So there were a lot of questions that came up throughout the chat of how do I find a support group? If you go on myasthenia.org under MG community, you will be able to find support groups. Most of them are still meeting via Zoom. It's just still a safer way in communities with high COVID numbers. And what we found is during the Zoom is that we've actually allowed people to join whatever meeting best meets their scheduling needs versus geographically. So I think most support groups have really seen a growth during this time. You can find the support groups. And before I mention two of the ones in Florida, there are also specialized support groups. There is a Spanish-speaking support group. There is a caregiver support group. And that actually has 2 different meeting times in a month to try and help out with scheduling. There's parents of children, and there is a young adults. In Florida, we have the support group that Pam and I co-lead, and it is the first Thursday of every month via Zoom at 7 o'clock. And there's also Dr. Pulley support group, which is the first Saturday of even months from 9 to 11. And you can find the Zoom link on myasthenia.org. For now, the Boynton Beach group has joined the St. Petersburg support group, looking for a moderator for that group, a leader for that group. But in the meantime, we welcome everybody. We're so happy to have people join the group. A lot of the support groups do a combination of education and share and care. So we tried to get speakers for every meeting. We don't necessarily have one for every meeting. So like our last support group, we did how to beat the heat, how to take care of yourself in the heat with myasthenia gravis, because we know most patients, not all, are bothered by the heat in myasthenia. So there are some good tips and tricks to do that. We've had Dr. Plowman, who you saw today. She's always very willing to present at a support group. We have a nutritionist that we're working with now to talk about side effects of medication and how we can leverage our nutrition to help with those GI side effects, or the hair loss with prednisone, or the weight gain with prednisone. So some pretty interesting things coming up, and you are welcome to join groups. So go on, see what one best meets your schedule, and it'll tell you how to go ahead and join that group. Any questions about support groups or health fair? I know I kind of went through that pretty quickly. And Dova has placed the link for the health fair in the comments if anybody needs to see that link. Again, myasthenia.org, MG community, find support group. So I know Dova has one announcement, and then what we'd really like to do, if there's anybody on here that's new and would like to have some sharing time, ask questions, we'd really encourage you. This is a good time. We're done a little early, so this is a good time for us to spend time with anybody who would have some questions. But first, I'm going to turn it over to Dova.
Thank you, Kathy. I just want to say thank you to our amazing volunteers today. So thank you to Kathy and Pam and Jenny for doing a tremendous job today, hosting our event. Again, I want to thank the sponsors. You guys have seen we have great sponsors, and we have so many new activities. The health fairs are coming up, and then also the online community is a new thing that we've launched that should be really exciting. So if everyone, if you go to our website, it's on the homepage and you can find the online community. And it's something where we can share things and make it our own. So it's very exciting. So take a look at it if you haven't already. I'm gonna stop sharing at the screen and let you guys do your chat. So I'm turning it back over to you, Kathy. Anyone that really wants to speak can unmute.
Anybody have any questions for, I know Melissa's still here. So
I have a question if I can ask.
Go ahead, Christy.
Hi, I am also seronegative, and I've hearing Melissa share her story. Definitely, I could relate to most of those experiences where the doctors weren't listening or you felt unheard and things like that. One of the challenges that I'm running into is the differences of opinion between neurologists. So I have some neurologists who are telling me, yes, I should have a thymectomy. I've got other neurologists telling me, no, you should run from any doctor that wants to give you a thymectomy. So as a patient, it's very confusing because there's such opposite opinions. So I wondered how other people handle that.
I'm running into exactly the same issues as you are.
Because I'm nervous to do, I had to have a very minor procedure where they gave me anesthesia and I responded very poorly to it. And it completely kicked back in the myasthenia portions that we had started to get under control. So I'll be honest, I'm very, very scared of any kind of a surgery at this point based on that experience. But if it gives me a hope of, getting back some of my skills and some of my life, I want to do everything I can, but it is very, very confusing to hear such different opinions. And I honestly don't know what to do with the information when it happens, because I have just as many people telling me to do it as I have people telling me not to do it. At that point, yep.
I'm sorry. Go ahead, Christy. Finish.
No, I was done. Thank you.
I understand the confusion and your concerns, because before I went to Dr. Weiss, I had my local neurologist saying you should really get this thymectomy, and then the one in Miami saying you're too young, don't do it. And because at that period of time, and this is just my story, I can't advise you how to do it because I don't know if I made the right decisions or not at that point. But I was on Mestinon only and I was doing great. So my thought at that time was, well, I've already gone this far with MG. I'm on Mestinon. I'm doing great. I don't need a thymectomy. What do I need it for? And then when things got really, really, really bad, and I saw Dr. Weiss and he said thymectomy, I was like, gosh, I've gone, I think it was like 19 years at that point, and I'd never gotten one. Is this even going to work? Why am I going to do this? I didn't have anything to lose at that point, and it could only make improvements in my life. But I did go. I went online to the Facebook community and I didn't ask thymectomy or not thymectomy. I just asked, like, for those of you that had thymectomy, did it help? And for me, and I'm not telling you what to do, for me, there was like this overwhelming response of people saying, well, I didn't go into remission, but it helped. And again, I was at a point that I didn't have anything to lose. So I just went for it, and I was really, really scared about it. And it was really fear that always held me back on it. And in my case, I had encapsulated thymomas. So I'm glad that I took that chance. And it did help. I'm not in remission. I'm not near remission, but I couldn't brush my teeth without going into crisis before my thymectomy. So for me, it helped, but I think that it's really important. You just have to make whatever decision, your instincts are telling you one thing, it's really a soul searching thing. You got to take all the facts and then go with your gut and figure it out. I kind of came to a point where I'm like, I can't let fear get in the way of me doing something that might be very helpful for me. But again, I didn't have anything to lose. I was already really bad. So I don't know what the right decision is for you, but that was kind of the process that I went through. So I hope that helps.
Okay, thank you.
Thanks, Melissa. Yeah, it's so difficult because we're all so different. So, we do encourage conversations with your healthcare provider. And if you think you aren't being heard, then like Melissa said, go on the myasthenia.org and look for partners in health, care partners. People have experience with myasthenia gravis, because just because somebody's a neurologist does not mean they know myasthenia gravis. I'm going to take one out. Tony, can I put you on the spot? I see you're on. Tony Giddles is on, and she runs the caregiver. She's lead for the caregiver support group. So I wonder if you could talk to us about that.
Yeah, it's great. I am a patient that has ocular myasthenia gravis, but I also have led support groups for caregivers in the past. So I am volunteering with MGFA to lead caregiver support groups. You all have your stressors having the disease, of which I am somewhat familiar, though my situation is not really stressful. I'm functional in everyday life and without difficulty. But the people that are in your life, the loved ones that either live with you or provide some care, support, and love to you, are going through a different type of experience completely. And they, I'm sure, have your best interests at heart. But sometimes as the care recipient, we do not pay as much attention to what their needs are. So, and they do need to talk about it, and they need a support group of people going through the same type of circumstances, just like we as patients with MG can get a lot of value from support groups with our people that are going through the same circumstances, have the same disease. So I would encourage you to bring up the idea of your loved one who is caring for you to attend one of the support groups to check it out. Even if they feel like they don't need support, there may be something very valuable in the conversation. We are having, for the first time, a guest speaker who is going to talk about relaxation and stress techniques this coming Tuesday, July 19th, as well as Saturday, July 30th. It's something that I have been studying as well: meditation, mindfulness, and relaxation. I wish I had had it a long time ago when I was caring for my mother, because the stress was unbearable. So this is something to explore for everybody, actually, but the support group is for your loved one who's caring for you. That's about, I don't know, anything else, Kathy, that I'm missing? I've had some people come that came once and then didn't come back, but their loved one said, try it again. So I now ask everybody, we're going to spend an hour and a half together. What would give you value? Why are you here? So we do go through that conversation at the beginning. People introduce themselves very briefly and they let me know what they need. So that way it seems I can make everybody happy and they leave with some value. So just let them know, check it out. A lot of people are coming on a regular basis and I really appreciate that. And some people, if you're going through a calm, less stressful period, you feel like you don't need it. You don't need the support. I would say come anyway, you know, encourage them that you'll get techniques on communication and effectiveness and just how to be a caregiver and relieve some of the stress between both of you that you're experiencing. Thanks, Kathy. Appreciate it.
You're welcome, Tony. You know, I always say our caregiver has the disease also, just not the physical symptoms, but they definitely suffer along with us. One of the patients was asking, does anyone have seronegative MG and positive for voltage-gated channel antibody? You can put it in the chat if you would like to, if you feel comfortable. And I do have a question as a support group leader, and I think most support group leaders would really appreciate your input. What type of educational opportunities or speakers would you like to see support groups do?
Could you explain education, please?
So where we could get a subject matter expert, Julie, somebody who knows a lot more about the topic than I would know. You know, like we've had Dr. Plowman before speak about exercise and energy conservation methods, that type of topic, because, you know, sometimes I can't help. I'm coming from my own perception, my own point of view, my own agenda, and I want to make sure that as support groups, we are creating something for everybody.
And if you don't think of it now, we could think of it later and maybe email one of us and just let us know. That would be great. Any kind of suggestions for the individual support groups would be fantastic.
Kathy, I think I had mentioned to you that I had been studying positive psychology, which is the science of happiness. And I've started lecturing in my community to caregivers about happiness and incorporating the principles. And what we've learned over time is there are practices that you can put into place on a daily basis that don't take very long, that actually increase your ability to find more happiness and joy in your life. So this is something I'm very excited about. And whoever knew it was that easy. I mean, you can actually become a happier person no matter what your circumstances are. And we certainly are engaged in challenging circumstances with this disease.
Yeah, I think Melissa even mentioned that she's made some of her best friends through this journey. Thanks, Tony. We may be talking about that. Does anybody have anything else that they would like to ask, bring up, comment on? You can take yourself off mute.
Can I ask a question?
Sure.
Is there a place to find a listing of doctors who specifically believe in seronegative MG?
We have our partners in care list, and those are the doctors that the MGFA recommends. Unfortunately, that's not a specific question that we ask, because they'll all tell you, you know, the same, but it would be good to get a recommendation from someone in a support group about a neurologist that they've gone to and had a good experience with. That's probably our best recommendation for finding someone, who is more seronegative friendly than someone else might be. We have a lot of support groups, and they're all online and through Zoom, you can attend a lot of different locations.
Thank you.
Great. Dova, do you have anything else before
No, I think we're good. Thank you to everybody. I'll let you close up, Kathy.
Can I ask one question, please, of Nandita?
Go ahead, Julie.
Sorry, Nandita, may I ask where you are located, please?
Louisiana.
Ah, okay. I was going to try and give you some lists of seronegative specialists, but I don't have one in Louisiana. So.
It doesn't matter. I would go anywhere to see someone. I've seen a few, and everybody's giving me like a different answer regarding a thymectomy. I would really like something which will induce a remission without having to take an immunomodulating drug, which is going to mess up my immune system. I don't tolerate those medications well. So I would take the name of any physician.
I too am willing to travel. I hope the group will bear with us for just a minute. I'll make this quick. To travel to try and find somebody who's.
Why don't you two exchange emails in your
even better
chat?
Yeah.
Go ahead and exchange your emails in the chat.
My apologies.
That's okay, no problem. And I think Daryl has his hand up, Kathy.
I'm sorry. Yes, Daryl, go ahead.
Just wanted to add a comment. I found Dr. Weiss by accident, actually. I live near him. And when my ophthalmologist suggested that I see a neurologist because he thought I had myasthenia because I had droopy eyelids. And I knew a friend of mine's wife had myasthenia, and I asked him what doctor his wife was seeing, and he recommended Dr. Weiss. I had no knowledge at that time about Dr. Weiss's reputation. And I got an appointment with a very long waiting period to see actually, I saw Dr. Rosario first, and he diagnosed me in 2016. And then later on that year, I saw Dr. Weiss switch to his care. And I later on learned about his reputation by people in a Facebook group when I saw people coming long distances to see him, and I was quite amazed. But he's been absolutely amazing for me. I've been really fortunate not to have been in crisis, and I'm thankful for that, although I really didn't have any serious symptoms until this last fall, and I've been battling that since then, trying to stay out of crisis. I've got severe COPD, and I fight that as well, but my doctors locally have been greatly cooperative with him, trying to keep me out of trouble. And I'm thankful for that as well. And he's also very cooperative with them. And I've questioned the thymectomy, and I've gotten chest scans annually. And I've had the radiologist pay particular attention to the thymus gland when they read those scans. So I've really tried to advocate for myself and push them to pay attention to these things and be very careful about them. And Dr. Weiss has also been very cooperative about that.
Right.
I've had a couple, I'm sorry.
We're going to have to close it out, Daryl. I'm so sorry. We need to be our best advocates. I think we heard that from Melissa. Just a note that if you are on a long waiting list to see a doctor, ask to be put on their cancellation list, as most doctors want that list worked, especially with COVID cancellations. They don't want to lose new patient slots. So with that, we're going to have to close out. But I want to thank Dova for always being so great with us and getting us where we need to be to get the information that we need. And our speakers today, Dr. Rosario, Dr. Plowman, Dr. Pulley, and our dynamic MGer, Melissa. Thank you, everybody, and we hope to see you at next year's conference.
Thank you. Have a great day.
Thank you.